Welcome, everybody, to the Royal Society of Medicine and this Medicine and Me special seminar, Living with a Serious Allergy and Anaphylaxis. My name's Julia Manning, and I'm the Dean of Education here at the Royal Society of Medicine, and you're very welcome today. We are a 220-year-old charity, and we cover clinical and medical, surgical, and even veterinary education. And we provide events for both public and for professionals. And it's a real pleasure to have you with us today on this particular topic, which is, I think, relevant to everyone in every walk of life. And the excellent lineup on the programme ahead of us covers management. It's very practical, which is always close to my heart. I do like practical emphasis in our programmes, but also very personal as well. We'll hear from patients around their experience and people's stories of what allergies, how they've impacted their lives, what it means to them, and ways that they have found through the system. So there'll be lots of practical tips as well as medical insights. So it gives me great pleasure to hand over now to Simon Williams, who is Chief Executive of Anaphylaxis UK. Thank you so much, Simon, for partnering with us today.
Julia, it's a pleasure, and thank you to all of the team at the Royal Society of Medicine for organising this event with us and to host such an important, I think, webinar for the afternoon. You're quite right that we've got a great lineup of speakers, and I understand that there are some 200 folk that have signed up to listen and watch this afternoon as well, which is very, very encouraging. The lineup, you're quite right in the way that Anaphylaxis UK operates is that very practical everyday support that we can offer. And it's enhancing people's knowledge and understanding, both as individuals, the families, but also working very closely with schools. And we've run an allergy-wise program now for, gosh, over 8 years, and trained and supported tens of thousands of school staff and schools over the years, and we'll hear a little bit more about that later. We'll also hear from individuals about their own personal experience, which is enormously important for us all to realize that we can do things. Getting on with life is a challenge for everybody, but those with a serious allergy, very often barriers are put in the way. Sometimes the challenges can be a bit overwhelming. So it's providing people with those practical solutions that we hope we can offer, both in terms of enhancing the knowledge, of course, and events similar to this, but also then supporting the businesses, large and small, on the practical things around the labelling or the ingredients or the information that businesses offer, or indeed the attitude that businesses have, such as restaurants, on being a positively welcoming place for people with a serious allergy, not being turned away or treated any differently because of their allergy. So the charity really is there to support people on every step of their journey. And I'm hoping that we can have a flavour of that today on this webinar. So again, thank you, and thank you to all of the speakers, as well as those that are both listening and watching this afternoon. So I'll start the first session, but I don't see Helen. I know she is running slightly late. So I'm wondering, I can see Adam in the waiting room. Adam, I know your timings are extremely tight and challenging. Is it possible at all that we have you first?
Yeah, happy to. Absolutely.
Wonderful.
Yeah.
Thank you.
No problem at all.
So it's a great welcome to Adam Fox, who is one of the leading champions on allergies. I know I'm going to embarrass you somewhat now, Adam, and I'm sure very many people will recognize you and certainly recognize your name as one of the leading forces on this and improvement, particularly professionally, especially in chairing the National Allergy Strategy Group, which is going from force to force, and how you're being able to pull everybody together and get to where we are, which is very exciting. You may mention some of that in your presentation, but I'll say no more, apart from congratulating you once again on your honour and receiving the OBE, which I'm not sure officially you've received it, which will come in a ceremony, but certainly nonetheless, Professor Adam Fox, OBE, over to you.
Lovely. Thank you very much. Very kind of you to have me. So all of that aside, I'm going to thoroughly unimpress everybody by now attempting to share my screen, and hopefully, let's hope it goes well. Love the Anaphylaxis UK as I do. I was given a completely unreasonable title to cover all of research in update in what is one of the fastest moving and most exciting fields imaginable at the moment. I mean, it's a joy to be part of this, to see so much change happening, but 15 to 20 minutes to cover all this is really tricky. So it's going to be a bit of a rattle through, because there's some things I just really want to talk about. I'm going to mention very briefly at the end some things that I don't have a chance to talk about, but let's see how we get on, and I'm glad that there's time for some questions and things later. These are my, I've just put on here some of my conflicts of interest, just because I'm involved in some of the studies that we're talking about and some of the changes that have happened, but nothing hugely material. There's 4 areas I thought it would be good to just touch on around anaphylaxis and what's changing. And this is really from a clinician's perspective, the things that are really impacting us day to day. One's about just the actual management of the anaphylaxis itself, so the acute management, but then the more exciting stuff, I think, in the sort of medium to longer term around advances in desensitization options, new medicines that we're using to try and reduce the risk of anaphylaxis, so things like biologics, and then some of the more novel approaches that aren't quite here but are very close to being here, some of them, and some of them that are maybe a few years off still, but just to give you a sense of how things are changing. But I really want to just firstly draw attention to something that's hugely important, which is the fact that there have been in the last 3 or 4 years some updates to the emergency management of anaphylaxis. And I think there's 2 themes that have gone through this. And if you want the most up-to-date guidance on this, there's 2 really useful places. The first is the MHRA, our regulator. They do really nice, these sort of infographics talking about best practice management of severe allergic reactions. But also sort of the final word is the Resuscitation Council, the RCUK guidance, which is updated regularly. And there's 2 important changes, I think, that have happened in the last few years. The first is this recognition that posture and positioning is really important, and that if you stand people up or try to move them around after they've had reactions, it can lead to worse outcomes. And there's been some really tragic cases that have brought this into very sharp focus. So rightly, the guidance now very clearly states that as well as there being a priority to get adrenaline into somebody through an intramuscular injection with their adrenaline injector as soon as possible, and making sure that somebody's calling for help and ensuring that you're ready to give a second dose 5 minutes later, you also need to make sure that you lie the patient down, ideally elevating their legs. And this takes the pressure off their blood circulation and pressure off their heart. If they're not comfortable there, particularly if they've got difficulty in breathing, they might feel more comfortable sitting up. But the important point is, don't stand them up, don't walk them around, don't let them go off to find help. Better that help comes to them. The other thing is, and I think this is a common misconception in the management of allergic reactions, I think a lot of people imagine that it's really important to get antihistamines in quickly because that will prevent a reaction escalating into a more severe one, and that's not the case at all. Antihistamines just give you symptomatic relief for the itchiness and unpleasantness of an allergic reaction. If it was going to progress, it's going to progress regardless. So if you recognize already that things are going the wrong way and that there are features of a severe reaction, anaphylaxis, then the protocol for managing that now no longer includes antihistamines because they're just considered a distraction. It's all about just getting on and getting adrenaline in, getting the position right, calling for help, and 5 minutes later giving another round of adrenaline, and 5 minutes later, if it's not getting better, another round of adrenaline. And steroids are also off as well. And that's because, interestingly, researchers suggested that when steroids are given, even a couple of hours further down the line, the idea being that it would prevent a sort of later recurrence of a reaction or flare-up of asthma, that actually it's associated with poorer outcomes. So helpfully, this actually makes the management of anaphylaxis algorithm simpler because it's all focused, especially in the early stages, just on getting the adrenaline in. And if that's not helping, then there are other things alongside it, so getting intravenous fluids, things like that. But the focus is, medicine-wise, is much more on adrenaline, and don't be worrying or being distracted by antihistamines or steroids. Of course, the big development, and this has been really exciting, is that we now have, potentially coming up in the next few months, alternative devices to administer adrenaline. And for many years, we've had jets and EpiPens and very, very effective devices at delivering adrenaline very quickly and getting a high plasma concentration, which is what you want, of adrenaline very fast. But we know that people forget to carry them because they're a little bit cumbersome. We know that people are frightened about using them, sometimes because of a misunderstanding about the safety of adrenaline, because it's very safe, but sometimes because they're very needle phobic. And the consequence of all of those things will be that there's a delay in the administration of adrenaline. And we know that that can contribute to poorer outcomes, that you get the best outcomes the earlier the adrenaline is given. So the idea that we can have a device that I'm going to have a quick rummage in my bag because I've got one with me. Oh, here it is. So this is given to me by a colleague from Europe, where this has already got its marketing authorization. We're hoping that this will appear in the UK later this year, but it's a pretty simple device that goes up your nose as far as, so your fingers are touching your nose, and then you just press firmly with your thumb to administer the adrenaline. Initially, it will only be available for the older age group, but we're hoping that soon afterwards, younger as well. It's widely available in the US now. Worth mentioning that it's not as simple as saying this is just simply going to replace EpiPens, because if you look carefully at the in the slide, you'll notice that when you look at the spike that you get of adrenaline and you compare it to an auto injector, the spike is a little bit slower and takes longer to appear. And that's possibly going to be reflected in how quickly nasal adrenaline treats an allergic reaction. So really, this is just an alternative that needs discussion with each individual patient as to what's going to be best for them. If it's a patient who isn't keen on using a needle and we know is going to have a little bit of delay as a consequence, then they're going to be better off with an Effis. Some patients might even want both. Others who are quite comfortable and happy to use an injectable device, they'll stay with that. There's more going on. There's been an announcement from a company called Anaphylaxis. They're looking at developing, or they're in the later stages of development and looking for FDA approval for anaphylaxis. So it's about the size of a postage stamp. It goes sublingually under your tongue, and you hold it there. And we haven't seen the detailed studies yet to look at exactly what the uptake of adrenaline is, but I'm sure that will all be forthcoming. But the really nice things about neffis, about this anaphylaxis, is that they're much more portable. They're going to be smaller. This anaphylaxis will fit nicely in a wallet. And much more temperature stable with a much longer shelf life. So there's some real advantages, and it's great that we're going to have options going forward. And then there's other really interesting things happening in the same space. So this is a very early stage development of a wearable. Wearables are going to be huge over the next few years. It's a real sort of shift in the way medicine's going to be done. But the idea that you can wear a watch and it will give you an early warning signal if you're heading towards a severe allergic reaction. So for people like me who do a lot of food challenges, do a lot of oral immunotherapy, so where we're giving kids things that they're allergic to, having this device on them to give us an early warning that things are starting to go the wrong way means that you can make sure you've got proper focus on that patient and you can be all over any significant reaction as soon as it develops. So emerging technology, really interesting, and we're watching this space carefully. I wanted to talk about oral immunotherapy. I'm not going to cover the basics, so this is something that's now a nice approved treatment. So Palforzia for peanut desensitization, capsules of peanut powder given in increasing amounts over a period of time to make you less sensitive, got its approval from the regulatory side in the UK in 2021. A few months later, it was approved by NICE, confirming that it was not just effective and safe, but it was also health economically beneficial to be available. And then we have this really frustrating situation where it was promised to thousands of people. It was estimated about 140,000 people in the UK have got peanut allergy and would be eligible. NHSE said that they would be treating thousands of people a year within a year or two. And here we are 4 years later after that announcement, still with probably less than 100 people altogether treated on the NHS. So essentially it wasn't backed up with the right resources, training, space that specialist centres need to be able to offer it. And at the moment, I can only speak for my own centre at St Thomas's, the waiting list was between 22 and 25 years, which of course is bonkers for a treatment that is suitable for children aged 4 to 17. So clearly unacceptable. And well, one of the frustrating reasons, and I do love this headline because it just sort of sums things up a little bit. You know, somehow the US healthcare system, you know, an American pharmaceutical company made peanut desensitization cost thousands of dollars when it's something that's done in a, you know, very widespread across the US with packets of peanuts or similar foods. So I think we need to look very carefully as a specialty as to how we're managing this situation, the involvement of industry and how it's potentially making things less accessible. And that's a theme that will come up again when we talk about biologics further down the line. But the good news is the way that the wind has been blowing in oral immunotherapy, because increasingly, and you very quickly learn this when you start using Palforzia and desensitizing 4-year-olds and desensitizing 17-year-olds and discovering that it's a very different art and science. And increasingly, we're recognizing that food allergy in younger children, especially under 2 years of age, their immune systems are much more what we call plastic. They're much more open to change. And when you look at studies that offer very early desensitization, we see much better safety profiles, much better outcomes, a much greater likelihood that the child will actually be able to introduce that food regularly into their diet than you might see in an older child, where you get more side effects, it can be harder going, and they're more likely just to be less sensitive, which is helpful, but not able to really introduce that food fully. But if you look at all the studies, traditionally they focused on older kids, and that's because we knew that a small number of younger kids would just outgrow their food allergy. Peanut is 20%, tree nut is 10%. So understandably, initially the focus was on older kids, and it's only more recently that it's been focused on younger kids. But most of the data relates to peanuts. There's not that much using sort of real world foods rather than pharmaceutical products like Palforzia. And it's great now that we're seeing some really important publications that are looking at what happens when you try and do this in younger children and what the outcomes look like. I'm going to touch very briefly on this study. It was just published very recently, and a couple of months ago. It's from San Diego. They looked at their own practice over the last 7 or 8 years on a range of different protocols using different foods, and not just peanut, other foods as well, but always using just shop bought foods rather than pharmaceutical products. The protocols were all quite different. They got them up to different levels of desensitization, some of them just to a peanut's worth or 1 nut's worth of tolerance, and some of them significantly more, 8 to 10 cashews or peanuts or walnuts. But importantly, by doing this in a very young age group, they're able to show that many of them could have their dose increases done at home, and that this was very safe, and that they really didn't report any significant reactions, certainly a lot less than the studies that do this in older kids. And opening up the possibility that if you can do this with shop-bought foods, if you can do this with a degree of home-up dosing, this suddenly becomes a lot more practical than the model that Palforzia was based on, where it's an expensive pharmaceutical product, requires a lot of visits to hospital. But the key, of course, is getting in there really early and doing this very timely. And that can be a challenge, especially on the NHS, when there's big delays in getting your diagnosis in the first place. The other thing that's a huge amount of interest in the area is thinking a little bit beyond just desensitization, the idea that we can get you to the point you can eat a couple of peanuts or a couple of cashews without reacting. And yes, that makes you safer when you travel, when you're eating out, but wouldn't it be better if we could achieve not necessarily tolerance, that's the holy grail, getting somebody to the point that they can just eat something completely freely, but getting to the point that they can eat it broadly freely and not be overly reliant on regular dosing in the longer term. That's, of course, something we'd love to be able to achieve. And a lot of studies are now exploring where that's going to be more viable. This was a really important study called the IMPACT trial. It was done in California. They got a couple of hundred kids who were allergic to peanut, but young, under the age of 4. So still in the window when potentially they could outgrow it, confirm they were allergic with food challenges, and then randomize them either to be desensitized, 2 out of 3 of them, and then the third out of the 3 was in the placebo group and didn't get active treatment. But of the ones that got treated, they would go through a program all the way up to sort of about, 8 peanuts worth of peanut, given small gradually until they're able to tolerate that. And then they continue on that dose until they've been on the program for a couple of years. They're then given a food challenge to see whether they're okay with a much larger dose of peanut, 5,000 milligrams, so about 20 peanuts. And then, and this is the exciting bit, they then are told, right, stop eating peanut regularly for 6 months, and then come back and let's see if you can still eat 25 peanuts or so, i.e. have we essentially put you into remission? We avoid using the word cure because you never know what the long term is for these guys. But the idea that you can not eat any peanuts for 6 months and still then come in and eat 25 peanuts in one go is as close as you're going to get, and what we'd refer to as sustained unresponsiveness. And what this study showed, so they got about 150 kids, all under the age of 4. They described a few significant reactions, but certainly within a sort of acceptable safety profile. They have a very low threshold for using adrenaline in the US, it's worth mentioning, but actually only 5 significant reactions. And those are usually reactions that do respond completely to a single shot of adrenaline. But what they're able to show is that the majority of kids, and so in the top we've got what we call intention to treat, which is basically the outcome of everybody included in the study. But when they look more carefully just at the people that completed the study as they were as was intended, what we call the per protocol, you can see more clearly what the proof of concept looks like. And what this showed is that a very significant majority, 84% of these kids, successfully got taken to the point that they could eat 25 peanuts, and still 30% of them were okay 6 months after avoiding it. And if you look in the placebo group, very, very few of the kids achieve that. So this isn't by any means a sort of, panacea or universal cure, but a treatment that can get to the point that 30% of those peanut allergic kids are essentially able to eat peanut freely without any restriction, and most of the remainder are able to eat large amounts, albeit having to have it regularly to maintain the effect. That looks pretty good, and certainly a big bump compared to what the initial outcomes were from the Palforzia trials in older children. Interestingly, when they looked at which of the kids that responded best, that got the best outcomes, it was the youngest children with the smallest allergy tests. And so again, it focuses the mind on making sure that you pick these kids up as early as possible in the clinics. And the guys that wrote this study and a couple of other studies have sort of come together with a very sensible model of thinking about, well, what should we be doing now when we diagnose children with a peanut or a tree nut allergy? And they're basically pushing very hard towards early intervention, because many of the kids, if they're treated early, some of them, yes, they'll have outgrown it anyway, but the ones that won't, you can get really good outcomes that still look like being able to eat peanut pretty freely when they're older. Whereas waiting, they either outgrow it, but often by the time they've outgrown it, they're very foodless and they really don't want to eat the food anyway. Or if they haven't outgrown it, desensitization is much harder to do and the outcomes are not as good. So a clear shove in the direction of early intervention. All of this has been very focused on kids. I'm very mindful of that. I know I'm not talking to an audience that's just about pediatrics, and I have to remember that, I'm in a little bit of a pediatric bubble in my own practice. So it was lovely to see this huge amount of attention that happened, really front page news, just a few months ago with Stephen Till's group at Guy's Hospital, when they essentially did something very, very similar, but in adults, because the general consensus is that this was a treatment for children and didn't work with adults. And this study showed pretty clearly that actually amongst a group of very motivated doctors and patients, you could achieve desensitization in the vast majority of adults. So this was a small study. It was only about 20 patients, but they were able to find confirmed peanut allergic patients, start them off at very small doses, 3 milligrams of peanut flour, but get them all the way up to 4 whole peanuts as a regular maintenance. And then after a period of maintenance, say 3 months on that dose, do another challenge to see just how much they could eat. And the outcomes were really good. So the majority of them had a marked improvement in where they were. There's only really one, what I guess we'd call treatment failure, where they didn't really get a meaningful change. And 15 out of the 21 were able to tolerate that large peanut dose. So, really, really exciting to see that this broadly mirrored what we've seen in much younger patients, that it is achievable in adults. And if you look at the immunological changes that happen, they very much mirror what happens when you do develop tolerance. Their IgE, their allergic antibody levels dropped, their IgG levels for peanut, which reflect a degree of tolerance, went up. So, a meaningful change, not just in the ability to tolerate peanut and be safer from reactions, but it will be interesting to keep a close eye on what happens to these patients after a long period of continuing treatment to see whether they essentially go into remission. And alongside that, we've had a bit of a revolution. This is a picture that I think this is the advert for Xolair, this omalizumab medicine that's become available in the US. It's not a new medicine. It's been around for 20 years as a treatment for asthma. It's also called anti-IgE. So it's what we call a biologic, so a monoclonal antibody, an antibody that sticks to allergic antibodies and stops them from working properly. And consequently, it interferes with allergic reactions. And we know it's very safe because it's been around for allergic asthma for a long time and chronic urticaria. But last year there was a license for food allergy in the US. This is now advertised on TV, remarkably, because that's how they do things in the US. So I routinely get sent by friends who are visiting the US. They'll send me this picture and say, "Did I know there's a cure for food allergy?" It's not quite a cure, but it's really a really exciting medicine to be using in food allergy. So this is the seminal study, what's called Outmatch. So there's got a long title there, what it stands for. But essentially what they did is they got a couple of hundred patients who they did food challenges to confirm that they're allergic to at least a couple of different things. So usually peanut and then something like wheat or milk or egg or a tree nut. Once they'd confirmed that, they then went on 4 months of this treatment. Now it's an injection that it depends, your dose depends on your overall level of allergic antibody and your weight. So it might be 2 weekly or it might be once a month injections. And after 3 or 4 months of the injection, they were just brought back in and given the food again to see how much they could eat before they got symptoms. And you can see here, so this is how many of them could tolerate for peanuts. I think it was 1,000 milligrams. And for other foods, it was 600 milligrams. But you can see that a significant proportion of them are way more tolerant of the food to the sort of level that you might achieve if you did immunotherapy. And overall, only about 14% of people didn't show any improvement in their level of tolerance. So it doesn't work for everybody. But for many people, especially those who've got multiple food allergies, you can really give them a layer of protection. The problem, of course, is it only works for as long as you're on it. So once you stop it, you're back where you started. So have a bit of a conversation now of options that we can have with people with food allergy about what might be best. Because the biologic is useful because it means you get the effect for lots of allergens. It's a very safe, well-tolerated medicine. Only about 1 in 1,000 people get an allergic reaction from it. So beyond that, the side effects are pretty mild. But they have to have regular injections. It's really expensive. So if you're not in the US and it's not covered by insurance, that's going to be a major issue. And you have to have injections, and that's not going to make you any friends with younger patients either. And you just have to keep going with it. It never gets sort of, it stays the same all the time. And if you stop, you're back where you started. Whereas with desensitization, there's harder work at the beginning with a higher risk of reactions to the treatments itself. But once you've achieved a certain level, you've then got a long-lasting effect that needs maintaining, but is relatively straightforward to maintain. And you can just keep going with forever and not need injections, or there's no cost, etc. So risks and benefits of both sides. So it's certainly an option, although if it's not licensed and it's not covered by, the NHS, which I don't think is looking likely at all, or it's not covered by insurance company, the cost is probably going to be the death of this in terms of its option in the UK. But we can use it alongside oral immunotherapy for a few months, which makes it much more affordable, to make immunotherapy easier to do to more things at the same time, or for those patients who just can't tolerate immunotherapy because they're too sensitive. So it's an adjunct as well, working together with other types of treatment to maybe get better outcomes. And excitingly today, so research talks, it's good to be current. Today, the FDA announced Omliplo has just got its US approval. So that's a biosimilar. So it's a very similar medicine to omalizumab that potentially might be quite significantly cheaper, but we don't know what the pricing of it's going to be yet. So it's definitely an area that's going to be important to watch. Simon, have I still got 5 minutes? I've not really thought of my timing because I'm not sticking to this.
Slightly over, but since it's you,
Okay.
I'm sure
I'll be very fast.
on what you have to say.
I'm going to finish with just a few other exciting things that are in development. So home dosing. So one of the problems with OIT is that each time you increase the dose by a significant amount, there's a bigger risk of reacting. You have to come into hospital and you see more reactions. Well, what if we could do tiny dose increments so small that the increased risk is so small that you can actually just do dosing at home? And that's what they're looking at in Cambridge with a device that will measure out to milligram quantities the food that you're doing oral immunotherapy to. So this is an early stage trials, but that's an interesting opportunity, especially for people who live remotely from centres where they get access to immunotherapy. Another one we've been talking about for a long time, epicutaneous immunotherapy, where you put a patch of the peanut or food on the skin, and over a period of a year or two, it will make you less sensitive. That has now got its sort of more provisional approvals from the FDA. It does look like it's going to happen, probably not till sometime next year, but going to be really helpful for people who are super sensitive, which means it's hard for them to do OIT, or really don't want the restrictions of OIT about not exercising before or after the dose for a couple of hours. So it's going to be sort of much more practical, especially I think for teenagers, less of an issue for smaller children. And another modality, sublingual immunotherapy, where instead of giving you large amounts to eat, it's just squirted under the tongue. Small studies, but exciting ones, have shown really good effects. Takes a long time to work. The effect is more modest than oral immunotherapy, it seems. But again, it's a very important alternative option for people who don't really want to put the energy and effort that's required to do OIT, which is quite significant, or are very, very sensitive to it. So, it's great that we're going to have a menu of options. This has been in practice in some places in the US for 10 or 15 years. But the evidence is only really starting to emerge properly. There's some big clinical trials that will really confirm the underlying evidence for this. Oral mucosal immunotherapy, a bit like sublingual, but a toothpaste made out of peanut protein that you'll use every day as a way of making you less sensitive. Again, in early phase studies, but exciting. And a whole new class of medications that look like they might be a complete game changer. So these are BTK inhibitors, Bruton's tyrosine kinase inhibitors. This is essentially a signaling pathway that happens around allergic reactions that these medicines get in the way of and block. So this graph shows very nicely, small study, 10 patients, but this is the level of symptoms that these patients got at these different doses as you go along the axis at the bottom. So you can see, as you would expect from peanut allergic patients, you give them small but increasing amounts, they get more and more symptoms. Then the second group, the ones who've had this acalabrutinib, 2 doses orally for 2 days. That's it. And then the same people, when they're given peanut, get much less symptoms, only at much higher doses. So this is really potentially exciting. And this is already licensed, this medicine, albeit for other conditions. It's used for B-cell malignancies, not for food allergy. But this is getting a lot of interest, as are its cousins that are a little bit more specific and might show better effects. So again, it's a watch this space. Everything I've talked about requires lots of time, lots of expertise, and we have a huge issue in the UK about either of those in terms of specialist allergy services. Recent data suggests less than 10% of food allergic patients see anyone other than their GP. So there's sort of 2 parallel universes going on here: the reality on the ground and what's, and these advances that are happening in ivory towers. And my work at the moment is very focused around the national allergy strategy, about trying to lobby really hard for better provision of even the basic diagnostic stuff, not even the fancy stuff. But we really need to do way better in terms of accessing our patients much earlier if we're going to make the most of these treatments, and making sure that all patients with food allergy really get bespoke care that offers them all these different opportunities now that they're being developed, because at the moment it feels a long way off that. So apologies for running over, but I hope you've given you a flavour. There is loads going on. There's a lot evolving. Our work as allergists has profoundly changed. I think we have certainly gone over the line where we can't sort of look back anymore and just be a diagnostic specialty that tells you what you're allergic to. There are too many options, but we need better clinical services to be able to offer these, certainly within the NHS context, because at the moment we're not there. We need more time, we need more people, we need more space, we need all of those things, but then so does everybody else, and we're in a financially resource-restrained environment, so it's challenging. But thank you, and I promised the guys at the BSACI that every time I spoke I'll put this slide up at the end, so please come and see us at the BSACI in October. Thank you.
Absolutely fascinating. That was very, very interesting. What an exciting place this is. Thank you for sharing all of that. That's really helpful to know, and really look forward to those developments. I know you need to go, Adam, for a clinic, and can't join us for the panel, but a quick question, if I may, before you need to go. We talk a lot about food allergies. Clearly, there's immunotherapy that many people will know around bee and wasp venom. Is there anything around latex?
Really good question. So we are seeing incomparably less latex allergy than we did many years ago. And the main reason for that is that there's way less latex involved in healthcare. And one of the biggest challenges always used to be early exposures to latex, whether it was through catheterizations or medical procedures. And for healthcare professionals having a lot of contact, they were the people most likely to then develop allergies. So that less of that's happening. There are some studies looking at desensitization to latex, but you always have to balance the effort, energy, and risk involved in doing that versus, well, what's the risk of an accidental exposure? And certainly on a couple of occasions over the last few years when this has come up, we've sort of landed on the fact that because the healthcare settings are now so much more latex free, that the risk of an accidental significant reaction is so much lower that it will be difficult to justify going through what would be a sort of difficult process of desensitization with a very, very small evidence base behind it. So we've generally just settled with, you're just going to have to keep avoiding. So I think if there was more of it, or we had some very, very motivated patients, there's been a bit of proof of concept work demonstrating that you can desensitize to latex. But as with all immunotherapy, it's not just whether you can do it, it's whether you should do it and whether it's worth doing.
Thank you, Adam. Thank you for all your hard work. Without your leadership, I don't think we'd be in a good place. And pulling everyone together, pulling all those other organizations together to drive things forward really has made a significant improvement to where we are. We recognize we've got a long way to go, but I think we're doing it together, which is a great thing. So thank you.
Pleasure. Thank you very much.
Now then, Helen, where
I'm
are
with you.
Helen is the busiest person I know, if not in the country. So let's get Helen's camera on.
I was going to say, all right, hang on, there we go. Start my video. I'm not used to people not letting me put my video on. Hang on, is that working? I don't know why not.
While Helen's camera's starting to work, I'll just let people know that there's a Q&A button, which is kind of at the bottom of the screen. If people want to leave any comments or ask any questions, we can then raise these on the panel discussion after both Erin and Helen have made their presentations. And I'll try and bunch them together. Unfortunately, Adam had to go, but we do have Helen, and shortly we'll have Erin as well. So Helen Evans-Howell, Dr. Helen Evans-Howell, yes, you are the busiest person I know. You run both Dr. Helen Allergy Clinic. You're a GP. You have a very active Facebook group. You're a very busy mum, as well as doing everything else, including as a trustee of Anaphylaxis UK. So we're going to hear from you some of those tips. I'm tempted to call them those little secret tips, but I don't know whether I should do that. But they are those tips and tips that people might want to hear and just be armed with, having that back pocket when they go and see their GP, really to get the most out of that consultation.
Yeah, exactly. Thank you. Do I need to be given permission to share? There we go. Got it. Right, share. Yeah, I'm definitely busy, that's for sure. I'm sorry I was late. I've actually just recorded a podcast. So there we go. Right, so some tips from me. So just a very brief background. So I am a GP. I don't do very much general practice anymore, actually, for a variety of reasons, but mainly because allergy keeps me extraordinarily busy. And although I love being a GP, I guess my passion really lies in allergy. And a lot of the reason for that is because not only have I got allergies myself, and sort of going down the journey of having a child with food allergies and then my other children having allergies, I think it came to light that actually I had allergies as a child, that my mum sort of didn't really know what they were. And she listens to me lecture these days and says, oh, you had an egg allergy. And I did end up in hospital, but I think, 40 years ago, very little was done about it. And she was just told to avoid and not really given much information. But looking now, I realise that even though I was a doctor at the time, I knew very little about allergy. And I think really that's one of the threads through this topic today, is that the training that we receive on all levels of healthcare, not just as GPs and doctors, but nurses, midwives, everybody really, the level of training we get in allergy is staggeringly low. So even though I trained at Southampton University, where I then went back and did my allergy masters, so you can see they're a specialist centre for allergy, I had 1 day of allergy training at undergraduate level. And so it was no surprise that when Ethan developed milk and nut allergies, I was basically clueless, and followed this journey of making all sorts of mistakes with him, of not knowing how to read labels, giving him goat's milk, not recognizing when he had anaphylaxis. And I would often go to his consultant appointments, and I know his consultant very well, and he was lovely. But he would often say to me, why did you do that? And I think there was an expectation even amongst my colleagues that I should know more than I did. And I like to think it's not that I'm a stupid person, it's just that we didn't have training. And so often when you are going into healthcare settings, to your GP, to your health visitors, to A&E, to whatever setting it may be, you're probably in a position often where actually you know more about allergies and allergic disease than the person in front of you. Which, you know, there are not many sort of topics that we could say that about, really. And that's a bit staggering and disappointing. And it's why the National Allergy Strategy Group is so important, particularly the strand on education and how we can make sure that people learn more about it. But because of my experiences of knowing so little, when I was heavily pregnant with Gigi, my third, I went back to university and did an allergy degree, trained with the Southampton Allergy Team, which is a big allergy centre, for 5 years before setting up my own allergy clinic, Dr. Helen Allergy. And we see adults and children, and we're very excited to be, you know, at the cutting edge of delivering immunotherapy in the UK. I'm very proud to be a trustee for Anaphylaxis UK. And I think one of the reasons I love working so much with the charity is because when I was an allergy parent and as an allergy sufferer myself, I still wanted my young person to achieve everything that he could in life and live the life that I had dreamed for him and not be held back by allergies. So although it's completely normal and reasonable that we should be allowed time to grieve when our young people have allergies that we didn't expect, there are still ways, whether we give immunotherapy or not, that we can try to help empower them to live well. Yes, there will be adaptations. That's the realism, and certainly the person there sharing that her child has a latex allergy, incredibly difficult, and there will be changes that have to be made. But I feel, for me, that the reason that we had allergy in our world was because it found this passion for me in life, and a way of using my skills and knowledge to help others. And I know I see lots of allergy families do this all the time. They create businesses from their experiences to help others. Yeah, right, hang on, I can't read my slides because of this box. Let me move over the way. So we're just going to have a little look at the patient journey, the symptoms you might expect, what to do at a GP appointment, and very briefly touching upon secondary care as well. So I'll start at basics. So the first thing is an allergy. What is it? So it's an abnormal response from the immune system. So it's when the immune system is reacting to something that should be harmless, such as grass pollen, cats, dogs, peanut, tree nut, sesame, milk, whatever. And based on the symptoms that you describe, the timing involved in it, that's what's going to make us suspicious about allergy. And in some circumstances, there will be tests that we can do to confirm that, but there aren't tests that exist for all different types of allergy. So the history is absolutely crucial in diagnosing an allergy, and really should be the bit that you focus on and write really well when you go and take that forward to a doctor's appointment, because it will be what I will be drilling you with when you come in with me. Yes, but what about this? What was the timing? What were the symptoms? Because it's all about what you tell me, so that I can make sure that we give you the accurate diagnosis. Because, you know, as Adam said, 90% of people at least are walking around having never seen a specialist. And I can tell you from the number of consults I do and people I talk to online, so many people are walking around with a label of allergy and they don't even have any allergic disease. And that's really affecting their life and creates this massive anxiety that doesn't even need to be there in the first place, because they have not had an accurate diagnosis. And I just think that's just a complete tragedy in the UK, really. And you can see here, really, allergies are incredibly complex. Back along we had immediate allergies, the ones that give you hives, swelling, tummy ache, vomit, diarrhea, possible anaphylaxis. And when, Ethan's 16 now, he had a non-IgE allergy before having an IgE allergy. And I have to say, I've never heard of that. And now those non-IgEs have become increasingly complex with FPIES, food protein-induced enterocolitis syndrome. We talk about enterocolitis, about constipation now possibly being linked to allergy. And this is really difficult, and it's why I empathise massively with my colleagues in primary care, because we need to know a little bit about everything to be able to then make a judgment and often refer you on to the correct specialist. But with this field being rapidly changing, it's really very hard to keep up to date. And so I guess my plea is to help us as much as possible by sometimes bringing in information and fact sheets that you might find from Anaphylaxis UK to help us, you know, have a light bulb moment of, I really need to read a bit more about this. And then they will often then come back to you and book another appointment. The other area that we spend a lot of time trying to unpick is eczema, you know, and I think it's the one condition where everybody really often believes that it is caused by something external. And you will see so many ads online targeting people with eczema. Yes, but what's the root cause? And they're really, you know, it is a very complex condition with lots being learned. But fundamentally, we know that particularly when eczema develops at an early age, that actually it's because of mutations in the filaggrin gene, which is the gene that codes for our skin barrier. So rather than the barrier being nice and tight and waterproof, it is leaky and loses moisture. And that's the fundamental reason we have it. There will be flare-ups that happen that you will see triggers for, and some of that is food, environmental, stress, teething, illness. But it isn't actually caused by food. But you will find so often online people advising you to remove foods from the diet to try and get it better. And that leads us into this horrible vicious cycle of then potentially meaning allergies can form because we're stopping giving foods. And children with eczema are at much higher risk of allergies forming. So I really feel that children with eczema need a rapid early assessment to help them get good control of the skin barrier to prevent allergies forming and to try and give you the correct early information to stop you pulling lots of foods from your diet. So I guess a plea from me of go and see a professional, sometimes ask for that onward referral. I know that can be really difficult, but be very wary of well-meaning people online giving you advice about what to do, because they are often just sharing their personal experience. It doesn't mean it's applicable for you or your child, and can sometimes actually be quite harmful, which is a big reason why we set up the support group, why at Anaphylaxis UK we work so hard on making sure the information is factual, but often the fundamental bottom line is asking you to go and speak to a healthcare professional about it. And if you're not getting the answer that you want initially, you may need to go back and knock on some doors. And the problems when you just remove foods from the diet are for children, particularly, we will see issues with their growth. There will be deficiencies in their vitamins and minerals that may not be obvious to you, but it may have long-term consequences. It's really expensive to buy free from. You probably all know that. You can affect their taste bud development, so they may never want to eat this food again. It can allow allergies to form, particularly in children with eczema. If you don't give the food, we can lose an opportunity and allergies can then form. But I guess the biggest thing for me is the impact on your mental health, both as the parent and the person with allergies, in avoiding foods, potentially without good reason. I really, really see it every single day, how much of an impact that has on people's lives. So getting the diagnosis right at the beginning is super important. So your GP is often your first port of call. There, in some areas, health visitors are very well trained and will often give a nudge to the GP of, did you want to prescribe this particular formula? But it's very variable, and that's really difficult, isn't it? Because sometimes it's just, were you lucky enough that you got to see me as an out of hours GP and I really specialize in allergy, you're winning? Or are you seeing the person who really has no background training and you're going to be needing to look for different support? And that isn't good enough. And there's lots of work going on to try and change. So I guess my first tip, and this goes for anything to do with health really, is that go and ask the receptionist, see if you can find a nice one who's not super stressed, maybe go in at a time of day where it's not really busy. So not first thing and not straight after lunch. So in like the middle of the afternoon, and say who in the surgery is really good at whatever it is you want to see: women's health, heart disease, eczema, allergies. There often is somebody that is there, and ask to see them. And often the way that practices work now is that we collaborate with in my visiting job as a GP, I would look after the elderly, but actually of the 4 practices would often ring me and say, could you ring this person about allergies? Because they knew that I was the kind of go-to. So you might find that within your practice, there is someone who really gets it. So book an appointment with them. I'm really asking you to go in a very collaborative nature, and to be really mindful of what are you trying to get out at the end point, and thinking about, yes, how it feels to be the doctor. So at the moment as a GP, we have around 60 to 80 patient contacts a day. Can you imagine that? That's phenomenal. We are trying to change from one topic to another topic to another topic to another topic, to create rapport, to empathize with you. Whilst we're hungry, we've got our kids texting us, all sorts of life events that we've got going on as well. So we need you to make it as easy as possible. I am a talker. I'm a real waffler. I'm probably already running late, but you need to be succinct. So I know you want to tell us the whole story, because I hear this all the time of I didn't feel like I was heard. So I get that. But in my private consults, I've got an hour with you. But in my GP appointments, I have 10 minutes. You do not want to spend 10 minutes telling me about how you prepared the food and what, very slowly telling me about the reaction. Think about it as being the first 4 to 5 minutes, you want to give the information. So write out for me foods you're suspicious of. What was it you saw? What was the timing? How quick did this come? How long did it last? What did you do about it? What were the symptoms? If you've got photographs, put them in a specific album that you can quickly grab. Please bring me photographs. I want to see it. I want to see what you think the poo looks like, what the skin looks like, what the swelling looked like, and then I can make some judgments. The good thing as a GP is we can bring you back. There's no way on earth I'm going to be able to tell you everything you need to know about allergy in 10 minutes. But what you want from it is to give over the information and to get some immediate steps to keep that person safe. So if this is an immediate allergy, do you need an onward referral? And on the whole, the answer to that is yes. There are some centres where they won't do that for egg, but they will for most of the other foods. Do you need an allergy action plan? Ask them, could you go to the British Society of Allergy and print us off an action plan which they can sign? Do they need to be carrying EpiPens or Jex pens? If this is delayed allergy, do they need a referral to a dietitian? So think about what is it that you want, and that can be quite useful to go to the GP and say, I think that my child has a sesame allergy and I'm really keen to see an allergy specialist so that we can have allergy testing and discuss the next steps. I know right at the beginning what you want, and I'm going to work towards that. So make our lives simple. Leave us a nice printed sheet, and then I can scan it on the notes and have to type loads of things. These are the recommended NICE referral for who we should refer on. So anyone who's had anaphylaxis, they're multiply allergic, they're going to need more input. If they've got severe eczema, parental suspicion, even if we don't think it's allergy, is a reason that NICE say you could have a referral. Obviously issues with growth. And if you've got asthma and a food allergy, you've got higher risk of anaphylaxis. Now, what I would say is that even though these are NICE guidelines, we know allergy services are swamped. And so the really difficult thing for us as GPs is sometimes we refer for you and they write back and say, no, we can't see this person. We can be stuck in a complete hard place. If that happens to you, ask the GP, would you mind awfully if I have a quick look at the letter you sent? If they just wrote, please see Joe blogs, he reacts to tomato, but they didn't write within that actually the tomato sauce contained lentils, which might make us more suspicious of allergy rather than tomatoes that might just give you a contact red rash, the referral is going to get declined. So check that the salient points were put across in the GP referral, and then ask them to try again with a bit more information around it. But sometimes we are really stuck. So for immediate allergies or severe allergies, which I haven't got much time to touch upon, like FPIEs, where you have profuse vomiting, or eosinophilic esophagitis, where the food pipe gets inflamed, you'll need a referral on. And NICE guidelines say for the non-IgE allergy, once the GP has proved that that allergy exists by removing the food, see if things get better, put it back, prove that the symptoms come back, then really they should have a referral onto a dietitian. As I say, it doesn't always work smoothly, but that is the recommendation. In primary care, we can prescribe you antihistamines. We are allowed to prescribe EpiPens or Jets, inhalers. We will be looking at the guidelines of whether we can do that, but I find that GPs do want to help you explain your concerns and anxieties, and then we'll be able to move you forward. Simon, how long have I got?
We should maybe wrap up a little bit, but
Okay.
It's just so fascinating, and I'd love to have you talk for longer, but we've got
okay. I'll do a couple of minutes and I'll whip through my slides. I saw someone ask about the slides. You're welcome to have them for me. if a GP says to you, the NHS do allergy testing, you could just call them out and they're like, that's just a complete lie. Yes, we do. Yes, the GP can do some blood tests, but it is only recommended they do that if they can analyze them. If not, then they can refer you on. And those are the action plans. Talk to your child. Make sure you involve them in conversations about allergy. Role play is fantastic to do. Don't take them in the dark. Play doctors and nurses at home. It's really, really helpful to make sure that they are more settled for an allergy clinic. I don't think there's any. There's lots of movement, as Adam was talking about immunotherapy. It makes allergy consultations extremely difficult these days because we have to assess it, do the testing, give you information about how to live and navigate and manage. And now there's a subset of treatment options which are often not even available. But I think I want you to be with hope. It's totally possible to live a good life. There is lots of change going on in allergy. It's a really, really exciting time to be part of that. Lots of us pushing for change. It is too slow. I completely know that, but it is coming. But GPs are there to support you and be your advocacy as well. You just want to find the one that you gel with, but just go back and ask to see another person and make sure you go to good places for information. Follow people online that are doctors or healthcare professionals or dietitians or the charities. Don't take your advice off random bloggers. There we go.
Quite right.
Thanks.
Thank you very much. Sorry
worries.
to rush you on, but I'll tell you what we'll do is as well. May have mentioned earlier that we've got a series of podcasts. You've got your own a Facebook group and other tons of other. I lose track, Helen. I lose track. And we may well talk about this in more detail on a longer session in a slightly different way. How long have we got? We've got hopefully some questions coming through. Are you all right until about 20 past?
Yes, just about. And then I'm rushing for my train for the next meeting, but I'll be with you. I'll listen to this next speaker.
Wonderful.
Thank you.
Yeah. So is Erin with us here? There we are.
Hi.
Awesome. So Dr. Erin Alford. So Erin's working with us to help really develop a better understanding, but crucially, some mechanisms and tools on helping people with those anxieties that very often people live with associated with allergies. Erin, you're a counselling psychologist, and we're working with the University of Surrey down in Guildford as well to develop this suite of tools. But I think if you really help us and have a better understanding of the sorts of things that people may face, the challenges that they have, but also those tools that sometimes they can do for themselves with some support and potentially as well through Anaphylaxis UK.
Great, thank you. How long do I have? When do you want me to wrap up? Because I know the panel was meant to start at 5.
Hang on, let me play with my camera. Well, if are you able to go for 10-15 minutes?
Yeah, that's fine. I planned 15, but I'll try.
I'll put the camera back on in about 10-15 minutes time. That gives an idea. Then we'll see if there are any questions on the panel, and we can have a chat about it.
Okay, perfect. Great. Okay, well, thank you for introducing me. So there's so much to say about the impact on mental health. So this is very much a whistle-stop tour, but hopefully it is useful. So just a brief outline for what we'll cover today. So firstly, what is anxiety? And then we'll look at the impact on parents, on children, and then on adults. And then we'll have a look at avoidance, stigma, and shame. And then briefly impacting quality, specific parts of quality of life. And then we'll finish up on a more positive note, looking at coping strategies. How can we manage anxiety? So first of all, yes, what is anxiety? So anxiety is probably something that most of us here have experienced. I've experienced it before presenting today. So anxiety, as it says at the bottom here, it is, it's a a common experience. It's very normal, and sometimes it can actually be helpful or useful. So, getting some nerves before presenting, it can help to get you ready, get your energy levels up, get you more focused on the task that you need to do. So just to keep that in mind, that some level of anxiety is okay and it can be manageable, but at times it can increase and then start to have more of a negative impact on our well-being, or also things that we're able to do in life. So anxiety, typically, this is a very basic understanding of anxiety, but basically it is a reaction to something that is perceived as scary or threatening, and it can have various symptoms. So again, there's many more than this, but just briefly, it can be racing thoughts, ruminations, thinking over something that you've said or done, or something that's happened, and going over and over it in your mind, or maybe catastrophizing, thinking worst case scenarios. It can also have physical sensations too. So heart palpitations, heart racing, you can feel sweaty, clammy, maybe you're shaking a little bit. So these are some symptoms of anxiety, which maybe you notice can be quite similar to anaphylaxis symptoms too, which can be very tricky to distinguish from each other, which is just worth keeping in mind. So yeah, firstly, looking at the impact on parents. So research has found that parents of children with allergies do experience higher stress levels and also higher anxiety levels. And just a couple of studies here. So one found that a third of parents reported experiencing anxiety, and another 17.5% report depression before diagnosis. So it isn't just anxiety, it can also be low mood, depression, stress levels as well. And another part here is around that responsibility, burden, guilt potentially that can come from being responsible for looking after someone who has severe allergies, and this can be enhanced. So these experiences can be more so if the child has multiple allergies as well. So again, a very brief overview. I'm sure there is more, and I'm sure parents here will know how much of an impact it can have on your well-being. And so children and young people, so research has found that there is an increased risk of anxiety in children and young people, and especially as they transition into adolescence, where there will be more independence happening. And this in itself can cause tensions and difficulties, navigating those power dynamics as there is more independence coming, but it can also cause more anxiety both in parents and the children, as maybe the child or adult growing up child is moving out for the first time, living by themselves, cooking their own meals, or just there's less input from the parents at that point, which can be very anxiety provoking for everybody involved. And another aspect here, which is important to touch on as well, is unfortunately bullying, which you can see from this graphic here. 1 in 3 children with food allergies report bullying, and as well social isolation can come up too for young people who have allergies. So just thinking about the impact of the social environment and how that may have a negative impact on how children are coping. And as well, research has found that children are up to 4 times more likely to experience depression into young adulthood too. So it's quite clear the different aspects of mental health that allergies can unfortunately influence. But I've put in a quote here at the bottom from Walkner et al., relaxed readiness. So I think this is quite a nice way to think about it, maybe as a goal point, relaxed readiness. So having a good sense of what needs to be done to keep the person safe, what actions can be taken so that they can then go out into the world with that relaxed readiness, if that makes sense. And so adults, So interestingly, adults, it's been reported that they potentially have less support if they're diagnosed in adulthood as opposed to young people, because young people might have, families around them, more wider support, whereas adults might not have that same level of support. Also because it can be assumed that they're better able to manage a diagnosis of allergy in adulthood, maybe because they're older, more resilient, more emotional intelligence, but that's not always the case. It's still going to be extremely difficult to get that diagnosis and to understand it and what you need to do about it. And I've put in here some interesting statistics, interesting but also quite difficult to see, that PTSD symptoms have been found in one study in 12% of people in the study who experienced anaphylaxis, and in another study, 41% of 203 people with anaphylaxis have PTSD symptoms. So that's post-traumatic stress disorder, which you might know of people coming back from war or people who've experienced traumatic events can have PTSD, which can have a very significant impact on their day-to-day functioning and well-being. So I think this just really highlights how much of a serious impact allergies and everything that comes with it can have on our well-being. And so thinking then here, so avoidance and shame and stigma. So first of all, avoidance. So if we are uncertain about how safe we are going to be in a situation, then that will increase our worry, understandably. And this can then lead to avoidance. So an example could be somebody is asked to go to a cafe with a friend, but if the person can be sure of their safety, if they are where to go there, then they might not go, just to keep themselves safe, essentially, which can help to reduce anxiety in the short term. So if they don't go, they won't be exposed to that risk and they'll feel maybe better. But then the next time they're asked again, that anxiety will come up again. And then that's what we mean by the maintaining anxiety, that threat is still there and it's going to keep being there if we keep avoiding it. So just something to keep in mind with avoidance. And then shame and stigma also comes into that. So unfortunately, there can be some stigma with allergies, and people maybe being perceived as being fussy or picky or being difficult, asking about foods or allergens. And this can lead to then shame in people who have allergies, which then as a result can impact that social isolation of maybe staying home or being more reclusive if there is that worry about how they will be perceived if they go out with their allergy and need to ask questions. And again, coming back to the PTSD symptoms, shame has been associated with more severe PTSD symptoms, and also keeping those PTSD symptoms going. So the more shame we have, the more PTSD symptoms we have. And as a result, people are maybe then less likely to seek support if they are experiencing feelings of shame, especially support for the emotional impacts of allergies if there is that shame there. And another aspect is they're maybe less likely to carry adrenaline, which then, because they might be embarrassed to be seen with them, and then that of course might then have a negative impact on their physical health as well. So I'm just going to briefly touch on these because we don't have a lot of time, and there's definitely more areas of life that will be impacted by the mental health side of having allergies, but just a few to know. So, and this is coming from the inquiries that we get through the helpline and questions we get asked. So navigating dating and relationships, how to keep safe with that. Workplace stressors, so maybe if you're hot desking, moving desks around, shared kitchens, things like that. Traveling is a really big one that we hear a lot about through the helpline, and again, maybe people avoiding going on holiday, especially going on planes, because there is that anxiety around how safe they will be, and again, eating out as well. As I said, these aren't exhaustive, but these are areas that can bring a whole lot of anxiety to people, as well as then maybe avoiding doing these things. And that's not to say that everyone, some people might not want to go on holiday, so it might not affect them to the same degree as somebody who really would love to be traveling, but can't because the anxiety won't allow them to. So coping strategies. So feels like it's all been quite negative so far. And I think with Anaphylaxis UK, we really are trying to empower people. So whilst we recognise how much of an impact it can have on our well-being, we want to look at ways that we can manage that rather than avoid doing what we want to do. So greater control is one thing. So with this, it's really about informing people, which we are doing a lot of. And as from the little bits I saw earlier, you're giving a lot of information to people too, which is great. So this can help people to have more of a problem-focused coping style. So having a clear idea of what they need to do to keep themselves safe, a plan of action type of thing. And this can then lead to higher life satisfaction as well, as opposed to more of that avoidance coping style, which reduces life satisfaction. And then cognitive behavioral therapy, so CBT, that is one approach that can help people with allergy-related anxiety. And there's been more recent research on that, which has found it to be effective for specifically with allergies. And yeah, reducing depression, anxiety, distress, and improving quality of life. And then mindfulness too. So there was research done, if you've listened to our podcast with Chrissy Jones, they did a trial on mindfulness CBT. So the difference of this is really just more of a focus on more acceptance of our emotions, our feelings, our thoughts, our experiences, and coming at that with more self-compassion and being more mindful and in the moment. And that was found to be effective in supporting people with allergy-related anxiety, and things like breathing exercises, which you can get more info about this on our website. And social support is another thing too, which can be really helpful for managing all of the emotional impacts of allergies. So yeah, trying to find people around you that you can talk to, that you can share how you're feeling about everything. And one thing we are developing now is support groups for allergy-related anxiety. And that should hopefully help with what I was saying before around, shame around allergies, the stigma, the social isolation, that being around people with similar experiences or shared experiences should help with that, and hopefully then decrease anxiety and low mood and all of these things. So final point, just a plug to the Anaphylaxis UK resources. There's a lot there, so things like the fact sheets, podcasts, the anxiety webpage, which has some information there, the helpline, all of these things, which will help to give you information, but also some insight into how to manage anxiety as well. And I think that's me. Yeah, hopefully that wasn't too long.
Great. No, that was perfect. Thank you very much. So you mentioned there the podcast with Chrissy and yourself. We've got a series of podcasts which are super informative and helpful. You can find them on Spotify as well as the other equivalents just by looking at our, looking for Anaphylaxis UK, and some of the resources there that you mentioned on our website under the Living with Serious Allergies, and there's kind of a drop down, and there's tons of stuff there about going on holiday, traveling, and also that very important page that you helped write, as well as the video around breathing and mindfulness and so on anxiety. So Helen, let's grab you and Erin for the next 5 minutes. And I think you both mentioned around that the anxiety associated with sometimes carrying the adrenaline pens, so people being embarrassed or ashamed, or there's also that level of complacency, that they may not have had anaphylaxis and they forget them. And we were at the Free From show, Allergy and Free From show a couple of weeks ago. And there were tens of thousands of people there. Loads of people came over to our stand, and quite a lot of them didn't have their adrenaline pens with them. How can we, without being preachy and in the nicest possible way and that we try and do, just remind people how serious it is and how essential it is to remember their adrenaline pens without feeding the anxiety, making them more anxious, and talking about the consequences, but in a very positive way, reminding them. Helen, how do you talk to your patient?
I was going to suggest Erin did it. I mean, there's so many factors, aren't there, really, as to why people don't carry adrenaline or anything. Your inhalers, my teenager's an absolute nightmare. I think it's the knowledge that they need first and foremost of why are we issuing you these, and what are the consequences, what are the benefits, what are the barriers to you carrying them, and trying to sort of give all of that information to try and help empower them to carry it. I mean, there is always going to be an element of choice, isn't there, in these things? You can't make everybody carry them, and thankfully often anaphylaxis resolves. It's just that I always say we just don't ever want to be in the what if position where somebody does have a catastrophic outcome and you say, what if that adrenaline had been given sooner? That would be so hard to live with.
And we heard from Adam as well, the exciting prospect of new ways of administering adrenaline. So it won't necessarily always have to be this way, in that those bulky, awkward pens, carrying two, of course, in your pocket or in your handbag or however you might. They're not that convenient, are they? So there's that internal excuse that oh, I'm only popping out. I haven't got the room. They won't fit in my pocket. They won't fit in my handbag. I'll just do without. Erin, anything?
I think it's more to that, though, don't you, Erin? That it's not really just about the size and the shape, because at the end of the day, asthma inhalers are like that big now. The Neffy is going to be similar. If you have to take medications around with you for migraines, it's a packet of pills. There's so many layers that I'm sure Erin has more insight as to why people don't carry it.
I think exactly what you said is what I would suggest. It's really, with anything, trying to get people. Oh, I just realized how floating head I look. I hadn't seen this because my background's blurred. Sorry, guys. So giving people the information first and foremost. If we're wanting any kind of change in behavior, it's making sure they have that understanding of why you're asking them to do something. So why you're encouraging them to carry the medication. So I think firstly that's such an important part, so they understand why. And I think the barriers too, just really taking time to talk it through with them. Like, why is it that you're feeling uncomfortable taking this out with you? So if you're just telling them to do it then and ignoring what the barriers are, then it reduces that potential to have an open conversation about maybe there are anxieties coming up there, or maybe it is a worry about maybe somebody saying something, or they're maybe embarrassed, and then from there just having a conversation and seeing, do they need more support with that? That's really what I would suggest.
Thank you both. What a fascinating session that was. It was really interesting to hear all the different perspectives and the different angles that come in. Helen, you need to go and do another thing and catch another train and be in another place. I'm chairing the next session in your place.
Thank you.
And I understand that this whole day, the whole afternoon, is being recorded and will be available on the Royal Society of Medicine website imminently after the call, once the guys have done the editing or whatever needs to be done. But those that are watching, listening, do remember as well, sign up to our newsletter. We've got a monthly allergy outlook free electronic newsletter. Sign up to that, and again, we'll put some reminders and links and all the useful stuff that goes out in then, as well as when fact sheets are updated and any new developments. We always include it in those newsletters. And Erin, thank you very much indeed as well. So let's end this session. If I can't see any further comments coming through, a grateful thanks to you both.
Thank you.
Thank you.
So let's move on to the next session, which is all about the experience that everyday people have. And it's that lived experience that really runs through everything that Anaphylaxis UK does. And so we've got a panel of experts here. I can see Hazel. Hazel, would you mind? Do you put your camera on, or did the RSM do it? There we are. Excellent. Lovely to see you.
Thank you.
Hazel Gowland, Dr. Hazel Gowland. I can't explain enough. I mean, the list is too long for a start of all the wonderful things that you've done, but certainly involved with Anaphylaxis UK back in the day when it was Anaphylaxis campaign, when it was initially set up with David Redding. I won't remind you how long ago that was, but 30 years. And really instrumental in the way that both the charity initially started, but also influential in the way that things have improved. And we forget, that there are improvements, not just in medicines, and we've heard a lot about all of the technology that's out there, but also in attitude, in legislation, in the way that we just have that interaction with business, both large and small. There's a long way to go, and we're trying to do our best to make sure things are on that trajectory. But you've done an awful lot, Hazel, as that advocate. So it's a pleasure to have you here, and I'm looking forward to hearing what you have to say. Thank you.
Thank you ever so much, Simon. That's very kind. I'll see if I can share my slides. Okay, thank you ever so much. Now, I'm covering the patient journey here, and compared with what we've had already today, it's relatively naive, but I did these slides for the masters at Southampton that I've taught on for about the last 15 years that Helen was mentioning. And essentially, it does feel like this sometimes when you're living with allergy, because we're doing this for all our lives. I mean, I've had a nut and peanut allergy since I was 1, and I'm a lot older than 1 now. I'm not a medically trained person, but I hang out with scientists and food technologists and academics, clinicians, and so on. So I've been doing this, yes, in the middle, a sort of hub person for a long time. I have disclosures because that's what you have to have when you're doing medical stuff, but none of them are really medical. They're not really conflicts. They're just the breadth of people with whom we work. One of the that I think is quite important is down at the bottom, it's BSACIBAEN, Allergy Education Network. Now, I'm just a voluntary contributor, but essentially we're really trying to improve medical understanding of allergies through the BSACI and work out who needs to know what and who needs which skills. And I think that's quite an important part of that. I've also got health psychology projects, I've got shopping projects, and I'm just a little tiny cog in these major studies, which is such a privilege. Now, back in the olden days, 20 odd years ago, Dr. Pamela Ewan and Addenbrooks asked me to map this, and my husband, who's clever at this kind of thing, he helped me, trying to go from the top left circle, patient status, to the bottom right. And the thing here is that in 2000 odd, you used to have a GP who would say, well, they sent you away. Well, why did they send you? Well, I'm not sure why. Well, to wait and see. Well, told there's no clinic. Well, test yourself. Allergy clinics have been disbanded. Oh, adrenaline will cause you more problems. And that was the reality of trying to access patient care back in 2003. And of course, in some cases, it's not necessarily improved that much since then, but in many ways it has. So this is the patient journey. 6 steps. So there's recognition, patient access, diagnosis, treatment, allergen avoidance, and impact mitigation. So that's the sort of the standard course of events. But of course, this is ongoing, so you will be constantly reviewing it. And there'll be different triggers for why you would review these things. And one of them is you might have some new symptoms. There might have been an incident, you know, a major reaction which has needed a lot of attention. You may think you've got a new allergy. There may be key life stages where things get more tricky, as Erin has just been outlining. And then there's transition, the transition from being a child to being an adult, particularly through adolescence, when in allergy things are particularly exciting for some people. And then just generally improving your life skills and making sure that you can keep yourself safe as your life changes. So those are the steps that I'm laying out in this short talk. So recognition, now you know what it is. It's, what do we do? The babies come out in bumps or whatever. And of course, it might not be allergy at all. And the one important thing about seeing the right person is you need to know whether it was allergy and what you need, or maybe it's something else. There's that kind of symptom where you've got blotchy eyes, blotchy nose, maybe nothing much else happens. It doesn't necessarily progress to anaphylaxis, but in these allergy families, this is so common. And then you might actually have something a bit more, looking a bit more serious, where you might have loss of consciousness or difficulty breathing. But that's how real allergy really starts, particularly obviously in food, where I have a particular interest. So which door do you knock on? Well, maybe it's already done for you. You end up in A&E, or you end up with paramedics. Maybe you go to the pharmacy to get some help. Maybe you, yes, you're in a medical emergency. Maybe you just see the GP and you see what you can do about it. Those are the kind of doors that people will come through. And as Helen says, sometimes it's actually quite a struggle, and you need to be quite focused and have the right mindset, which is not easy when you're stressed and busy and you've got, you know, your different children to look after and all the rest of it. Then you need a diagnosis. Now, of course, the diagnosis, all the medics will say at least 50% of the diagnosis is listening and recording the history. And as Helen said, if you've got photos, if you've got timings are really important. And maybe sometimes you've even got a food sample or a label or something really helpful. It might not be a food, it might be a toiletry or product that you've been using. Of course, the expert allergy clinics have got great batteries of skin prick test solution like this. So you can have skin prick tests. Sometimes they want you to bring the thing that might have caused the reaction. They can do what they call prick to prick, straight from the food to the skin. And that's my skin prick test. I've got a very dramatic wiggly worm on that screen, which was 17 centimeters of what they call tracking. So I did actually have a systemic reaction to a skin prick test, which is not common, but it can happen. I was fine. Then there are the different treatments. Of course, if you're likely to have a medical emergency, if you're likely to have anaphylaxis, then you might be prescribed some adrenaline injectors. You might be needing to keep on top of your asthma. There are lots of different reasons why you may or may not be given these things. You may be prescribed other medication, or you may have over-the-counter medication. But then, of course, treatment moves on towards interventions such as early diet, perhaps. You might be talking about a weaning intervention, giving the food early before the baby's 6 months on purpose. Or if it's too late and they've been sensitized, then you might be looking at disguising the real food, perhaps having it baked or in some format like a malted milk biscuit here, disguising milk, on the guidance, of course, of a doctor or a dietitian, somebody who knows what they're talking about. Or if it's egg, they might be disguising it in a muffin. So various interventions that are available. And of course, there are more pharmacological interventions as well. So that would be counted as treatment, if you like, for the immunotherapy or the prevention. Then if you've got an allergy and you've got to keep avoiding, then you need help to avoid, because it's not easy. You need to accept that some events will look like this, or the kids at a party, or well, I can't have this and I can't have that. And we're all looking at the cake. And that's the reality of it. And of course, exclusion is a bit of an issue there. Then you've got to read all the labels, and you've got to know the rules about reading the labels. And this is a huge task in the allergy clinics, to have to explain all this, especially for people who've never done it before. And then, of course, in a catering situation, you need to know the rules for that. So in some places, they'll have a sign up saying, talk to the person behind the counter. We've got the ingredients. We can tell you what's in it. We know the allergens. But it's a task, and you need skills. Then there's impact mitigation, which is what Erin was talking about, which this is my little wordle that I made up years ago, but you can see the key words in here. We've got confidence and competence and therapy and trust and CBT, and then we've got excluded and guilt and all the tensions that happen. They happen anyway in families, but they're exacerbated when you have somebody in the family living with allergy. And that kind of blame thing, you know, where you said you were going to sort out this and you've given him such a thing, and oh dear, all the tensions with the grandparents and the friends and the lady next door, and it's difficult to deal with. Another issue is nutrition, particularly for people who are adopting a plant-based diet, because it's now recognized that if you stick to a strict plant-based diet, you might be missing out on some of the nutrients that you'd normally be able to have. But if you've got food allergies, then you won't be eating those things. So you'll be missing out on some of the nutrients, maybe. It needs to be monitored. And bullying and exclusion and all those sorts of issues as well. So those are the 6 sort of stages of initial allergy management. But of course, like everything, you'll have a review and you'll be constantly reviewing it. And you might have one of these other things that happen that will make you move on to wanting more support. You might have new symptoms, perhaps something that's not happened before. Or maybe one of the other associated symptoms, you know, eczema, asthma, rashes, hay fever, etc. They may all kick off. So new symptoms may cause you to start to reinvestigate. Or maybe there's been an incident. Now, this is a little boy who had milk by mistake in a cafe, and obviously he's going to be fine, but he's obviously had a nasty do there. And this is, I love this photo because this is the real life of being monitored for whatever it is, 4 to 6 hours in A&E. You just sit there and watch what's going on, and they watch you. And it doesn't happen to everybody, but if you've had anaphylaxis, that is one of the correct ways of monitoring people. But it's a young mum, and she sat in A&E, and she took that picture and put it on social media. It's just real life. Maybe you've got a new allergy. Maybe it's one of the foods that you know about already, one of the 14 allergens. Maybe it's something different like pea or bean or kiwi or banana or something like that. All the legumes are increasingly becoming a problem for some people. And of course, they're in everything nowadays. For the planet, they're a good idea. But for some people, they just don't like these allergenic proteins. Well, maybe, and this is particularly a thing for, shall I say, older ladies, that it's not only for older ladies, but it's a story I've heard so many times, that the shampoo in the hotel or the hand soap or the shower gel or the lotion contains something that they've never had a bother with before. But suddenly, at a certain point in life, they start to have trouble. So it could be not actually food, it could be something else. And then there are certain points that we know already, and it's already been mentioned, are challenging for some people. So obviously in pregnancy, you want to know whether you can do anything extra to help protect your baby from allergies, especially if you're an allergic person already. And what about when you're breastfeeding? Well, I think the guidance generally is eat a full and broad and healthy diet. And unless your baby really, really has trouble with a particular food that you've eaten, you just eat as broad a diet as you can and keep yourself as healthy as you can. Then, of course, there's early intervention, perhaps weaning, that sort of thing, where you're going to give a food on purpose a little bit early to keep it so the baby doesn't develop an allergy to it. Then you've got school meals, going to big school, putting your child in the care of other people. And then, of course, as you grow up, you're young adults, you're out and about eating, negotiating, talking, and protecting yourself. And of course, this lasts a lot longer. We've got care homes and people in older life also developing new allergies and living with older ones. Transition is a particular challenge, of course, as your teenager goes from year 7 up. Then the care system, the healthcare system may let them down. They may find themselves in an adult clinic, which is nothing like the kind of pediatric support that they had before. And then they go out in the big wide world and they go to college and they take things and they do things and they travel and all the things that Erin was telling us about. And they need protection and they need life skills. And they can improve the life skills. And as Adam mentioned and other people mentioned, I always put that picture up because it's basically don't go to the loo on your own. Always tell somebody, don't disappear off because you're ashamed. Just say, look, I've just got to go to the loo. And if I'm not back in a few minutes, come and get me. Because if you're having a reaction, you might go to the loo, sit down, feel a bit better, stand up and empty your heart. And so we want people to understand much more about posture, which is also what Adam said. So that's that's the correct posture for a person having anaphylaxis whose symptoms are primarily consciousness or loss of consciousness, not breathing, and who themselves are conscious. So that's resuscitation, counsel, guidance. Then you've got relationships and intimate contact and all those sorts of challenges. And then you really do need to carry your auto-injector and use it and be really super confident. And so does everybody with you, including having the instructions on your phone and your mate's phone and your grandma's phone and all the rest of it. It's really important. Everybody's got that. I like this picture. It comes from Anaphylaxis Canada, but it explains how complicated symptoms can be, especially as you grow up. So you've got neurological stuff, which we didn't really realize before, but being a bit floaty, you know, we knew about the cardiovascular stuff, but yes, all those things, we need to have good education on that front. So the conclusions are that the patient well-being is shaped by the patient journey. There are 6 initial stages, and the well-being, as for other chronic conditions, depends on effective review by invitation. So they need to call you in and you need to be able to knock on their door. And you need to be able to get a clinical review when you need it, particularly at those key stages. You need diagnosis, you need interventions, timely interventions, and the patient risk can be mitigated by timely progression through the 6 key stages, regular reviews and accessible interventions. Thank you very much for listening.
Great, thank you. That's really, really interesting. I'll just remind everybody as well, who may just have joined us, but look in the, I'm pointing that way, and I hope I'm not pointing at somebody's head, rather than where I think I'm pointing, which is a little button at the bottom of the screen that's got Q&A on there. There are many comments, many questions already there. We're encouraging you, if you wanted to raise any points, maybe we can answer them as we go along, but we'll try and save them to the end. We've got Elia in a minute and then Robbie, and then I'll hand over, because I think people have heard enough from me, to Louise, who's one of our trustees, to then chair that session and chair that panel, the Q&As, and then I'll hand it over. But Elia, it's lovely to see you. Thank you.
Oh, thank you, Simon.
Thank you ever so much for joining us. Now, it's your son Eddie, if I remember rightly, a number of allergies, and you're going to talk to us about your experience as a mum. That will resonate an awful lot with, I think, some of the speakers as well as those that are listening as well, and just your experiences really of just going about everyday life and some of those challenges that you face, but also as a family and your son.
That's correct. Thank you so much. Well, thank you so much for inviting me. My name is Elia. I have had anaphylaxis. My experience was terrifying and painful, something I don't wish on anyone, especially a child. My anaphylaxis was idiopathic, which means the cause is unknown. I cannot take steps to prevent it. I can only be prepared. But for people with diagnosed allergies, prevention is possible. With the right awareness and planning, the risk can be significantly reduced. My son Eddie is 17 years old, and he has given me permission to share his experience in the hope that it raises awareness. Eddie lives with multiple food, environmental, and animal allergies, including milk, He also manages eczema, hay fever, pollen food allergy, and eosinophilic esophagitis, or EOE, which is an allergic immune disease which causes inflammation in the esophagus. Managing his health is not just about avoiding allergens, it's also about creating a fulfilling and enjoyable life. For us, this begins at the supermarket. We have to check food labels every time we shop, even if we have bought that product before. We also keep update with the Food Standards Agency alerts, just in case of recalls or mislabeling. We have to research restaurants online if we want to go out. We luckily now more and more restaurants are producing allergy menus. But we really need to prepare for eventualities, and we usually carry safe food for flights or hospital visits or even social events. It is not just about food either. For example, at home, we have to replace our carpets with hard flooring to avoid exposure to environmental allergens like dust and pollen. But the biggest sacrifice is the fact that we cannot have pets. Of all the things Eddie cannot have, the thing he misses the most is having a dog. It also means managing health through care and routines. Eddie has to go to hospital appointments. He has to follow a daily skincare routine, which sometimes involves using topical steroids. He also needs to take medication for his hay fever and EOE to reduce the inflammation. It is a lot to manage for a young person, but it is necessary for him to keep healthy. School can also bring challenges, not just for the families, but also for the schools. In our experience, those challenges can be managed by awareness, planning, and teamwork. When we used to visit schools and communicated Eddie allergies, they used to say, "Oh, don't worry, we are a nut-free school." And then we told them, "No, but Eddie is allergic to milk too," and that will take them aback. So I think these nut-free policies can give a false sense of security and leave some schools unprepared to deal with other allergies. At primary school, Eddie was giving food containing milk by mistake. He had an anaphylactic reaction. It was terrifying. He had nightmares for weeks afterwards and kept asking why everything bad happens to me. The school was shocked too. The chef, having looked after Eddie so well for years, one day made a mistake. But it led to positive change. The school introduced a 2-adult check for all allergy meals. So this meant that the responsibility of checking these meals wouldn't just follow in one person. After that, my son didn't have any further incidents at primary school. Going to secondary school brought new challenges because Eddie decided to follow his brother and go boarding. So all meals were provided by the school, and also medicines. There were some few close calls, which meant that Eddie lost confidence in school meals, and he began to skip them, lost a lot of weight. Fortunately, we have the help of an allergy psychologist that helped Eddie regain his confidence. But there were also incidents of exclusion, unfortunately. When there were social events, sometimes the school will forget to cater for Eddie. They will bring pizzas and Eddie couldn't have anything. Or at tea parties, everything had milk. So nothing was done, obviously, intentionally or maliciously. But because of the lack of planning, Eddie felt embarrassed, invisible, excluded. So, determined to help, I began researching and came across two really helpful documents. One is supporting pupils with medical conditions at schools, and the other is disabled children and the Equality Act. What teachers need to know and what schools need to do. This is because some serious allergies can be considered disabilities. These documents highlight the importance of awareness, forward planning, and strong partnerships between the schools, the parents, and the pupils, and also explain the roles of individual healthcare plans and reasonable adjustments in creating safer and more exclusive spaces for children. Yes, we have had challenges, but we have seen real progress too. I'm very grateful to Eddie's schools for working with us and improving, becoming better places and more inclusive and safer for children with allergies. Apart from school, there are social challenges too. Going out with friends, holidays, dating. So when Eddie was younger, obviously the responsibility of communicating his allergies fell on me. I will speak with, if he went out with friends or visit friends, I will speak with the parents and explain his allergies. I will also tell them where he kept his auto-injector. And actually, I trained some of them with the use of a trainer EpiPen. The response was always positive. I think people is very altruistic. They wanted to help. His school also, with his permission, shared his allergies with his friends, and a lot of them became very supportive, helpful. If they went out to eat, they all made sure to choose a restaurant where Eddie will feel comfortable. And if he went to visit friends also, I usually will send him with his own food. A milk allergy is quite difficult to manage. I also sent him with treats that he could share with his friends. It was good for him to feel that he was eating the same things as other people. It's great to share dairy-free treats for people to know them and see they are delicious too. Dating also brings challenges. His girlfriend needs to avoid allergens before kissing him. These are not easy conversations to have, especially for teenagers, but they are necessary. So when we go on holiday, we not only plan where we are going, but also where we are eating. That is now easier because a lot of restaurants are publishing their menus online. I have also been known to contact the local allergy organization. For example, Food Allergy Canada was amazing, giving me tips, explaining the difference with labeling regulations in Canada. Most importantly, they gave me access to a Facebook support group of the area I was visiting, whose members recommended restaurants and even offered help if I needed. So, love Canada. Well, Eddie has transitioned to self-care. He carries his auto-injector at all times. At the beginning, he was hesitant, but his consultant made a great analogy. She said, Eddie, what is the first thing you do when you get into a car? You put your seatbelt for protection, not because you think you are going to have a crash. So that's the same thing you need to do with your auto-injector. As soon as you leave your house, make sure you have your injectors with you, just for precaution. So that clicked on Eddie. And since then, he is happy. He is always taking his injector with him. But obviously, sometimes he may he forgot them. So what we did, we put the injectors in an allergy bag, and we put an air tag. With his permission, of course. He was really happy about that. So if he goes, if he leaves the house in a rush, and then if he forgets the allergy bag, his phone will alert him, hey, your allergy bag is at home, and he will come back. So despite all the challenges, there have been really loads of positives. Eczema and asthma made sports difficult, but Eddie found joy in music. He was a member of the National Children's Orchestra, and he earned a place at the Junior Academy of the Royal Academy of Music. We have met amazing medical teams and professionals, and Eddie loved participating in allergy research. It made him feel that he is part of change, and it gives him hope to see all the developments. He has surrounded himself with amazing supportive friends. His schools have become safer and more allergy aware. As a family, we are closer and we are healthier too, because cooking from scratch is safer and we all benefit from that. We do visit allergy-friendly restaurants. The dining experience have really improved. But obviously there are cases where that's not the case. And when that happens, we speak up. If the risks are high and we have safety concerns, we will report things to trading standards. And this is not about allocating blame, but it's about improving safety for everyone. I will not hesitate, because that could save a life. What are my hopes for the future? Well, our hopes for the future: more awareness, more understanding and compassion, more specialists, schools and institutions taking allergies seriously, not just as a food concern, but for inclusion too. But above all, I hope we all can change what normal means. I hope we can change our perception of normal. I have heard many children saying, I don't want to discuss my allergies. I don't want to talk about them. I don't want to carry my injectors. I just want to be normal. But what's normal? What is normal is that we are all different. And that's something that we have to embrace, not hide. So allergies can affect all aspects of life. But with the right awareness and planning, we can create a better world for children like Eddie. And that gives us hope. Thank you very much for having me.
Wonderful. Thank you very much indeed. Some very positive comments as well in the Q&A. And I just do encourage everyone to ask the panelists, the speakers, any questions. And we'll raise these later on, or Louise want to hand over. But also remember the next session as well is about schools and the experience of teachers as well as parents, and an expert school nurse as well. Just so put the comments in, get that conversation going, get the questions in there. So thank you very much, and thank you as well to Eddie in his absence for the stories that you've shared. Very, very, very powerful, very, very helpful. So I'll invite now Robbie. I can see you you're there, but not with your camera on yet. So I think it's the chats. There we are. Awesome. So Robbie Epsom, you have got many personal experiences. You're an expert in the lived experience area. You've got lots of enthusiasm. I must say, and thank you as well again for running the London Marathon for us. So, you know, what a challenge, and a very admirable challenge that was. But we've been talking for a little while now around a range of kind of where we can make things better, and it's going to be great to hear from you on some of the where we're going with some of that, but also some of your own experiences about traveling, your own family experiences, and so on. So, really interested to hear what you have to say, Robbie.
Brilliant. Thank you, Simon, and thank you for the opportunity to speak today to the Royal Society of Medicine and Anaphylaxis UK. It's very rare that you have a condition like anaphylaxis and actually get the chance to speak to the relevant community and hopefully influence some positive change. So in my 15 minutes, I plan to give really just a quick overview of what I've experienced personally living with life-threatening anaphylaxis, and 3 things which I think are observations across my time with anaphylaxis, working with organizations like Anaphylaxis UK and Simon and others, that I really think we can actually do something about at scale. And those are the 3 bits that I'll focus on later. But if I just maybe start with an introduction, obviously my name's Robbie Epsom. I work at CBRE Investment Management at the moment. I'm the EMEA head of sustainability there. So there's an opportunity there, which I'll come back to in a second, about scale and solving this in the workplace. And that's one of the 3 things I want to talk about. But if I step back to my own personal journey, and I have a son also who has life-threatening anaphylaxis to peanuts and likely tree nuts as well. But I'm not going to speak about his experience because he's still finding his way, and as we as a family with what that's going to look like, particularly as things evolve. So I'm going to speak from my own perspective. And I found out at the age of 5 that I had life-threatening anaphylaxis, or at least an allergy back then, to tree nuts. So unlike many, I'm okay with peanuts. As many of you will know, that's a legume. I'm on the tree nut end of the scale, and some of them, like walnuts, hazelnuts, Brazil nuts, are particularly bad. And I really have in my time kind of lived through all the problems which I think many of us talk about in the press, through many of your conversations, whether it be allergies whilst traveling abroad, on an aeroplane. My first allergy at the age of 5 was in the middle of Nairobi Game Park. I grew up in East Africa, in Kenya and places like that in the Middle East. And so I've had allergies in quite a few different countries, and equally seen how different medical systems have responded, which I think is also useful information. And with many of us, when we get the allergy for the first time, when it's things like tree nuts and peanuts, those food allergies, it often presents as just something like a stomach pain, an upset, sometimes vomiting. And so there is a journey. And back then, when I was 5 years old, and this is back in sort of 1990, it really wasn't as well understood as it is now. And obviously, even now, it's still evolving. But even back then, there weren't as many people with allergies, so you were even more of an anomaly. It really wasn't something that was understood at all. You didn't have as many as you do today. And I think the prevalence and the increase in both people suffering with life-threatening allergies, but also the actual allergens themselves at the moment is quite terrifying. One of the kind of key things I noticed in my experience is I got caught out on an aeroplane, and I won't name the airline because it's not necessarily relevant, but with that, it's very interesting to see, and I think this is starting to evolve. I know Anaphylaxis UK have had conversations on this very matter. Back then, when I got caught out, they didn't even have EpiPens on the airplane, and I think there are still many cases where that's probably still true today. And I had to make that judgment call of, do I administer my EpiPen on the plane? And these things sound obvious now. Use the adrenaline pen straight away. But back then, there were sort of worries about, could I have a heart attack if I used it? And so I remember having to gamble on things like, do I wait the sort of 20 minutes till we land and do it at the airport where there's medical supervision? Because there really isn't confidence with things, and this is back then again, that people knew what they were doing. And if I did administer it on the plane, was I going to have some kind of issue? So back then, that was the trade-off. I did it. I waited till we landed. I typically have about a 45-minute window, and I know how my reaction goes before it gets serious. And so I felt confident that I could get to the hospital in time. I've had cases where I've been traveling on business trips, and this is going to be one of the 3 points I talk about in a second, where I really have, and I'm good at telling people I have allergies, explaining it very clearly. And even in spite of that, I get caught out because of challenges in language and culture and the way it's described. And the most recent one for me was only a couple of years ago in France, and I was on a business trip. I was literally 5 minutes to going up on stage very publicly to speak. I'd actually had an allergy, believe it or not, only 2 days before, and that was a more mild one, which for some reason didn't go to full-blown anaphylaxis. And so my view at that time was maybe this is just anxiety, and you hear about that a lot in the press these days, is am I just having a panic attack because I think I've eaten a nut? And so I kind of started toying, even, this is someone with years, a lifetime worth of experience with anaphylaxis. I'm still there questioning whether I use my EpiPen. Has this actually happened? Because they assured me there were no nuts. Should I use my pen or should I wait and see? And again, for some reason, despite all I know, despite all I've read, despite all my experience, I put it down to this can't have happened twice in a row. They've assured me it must be fine. And so I carried on to my event and just assumed that it was me overreacting. And then sure enough, 5 minutes before I went on stage, the anaphylaxis elevated, and I actually had the worst anaphylaxis reaction I've ever had, and actually almost didn't make it to my EpiPen. And one of the key things I've learned from that, and I want to cover this before I move on to my 3 key points, was actually I now carry 4 EpiPens when I travel, not 2. And the reason for that is because twofold. One, EpiPen's a prescription, and if I have to use 2 of them when I'm abroad, there's no guarantee that I'll easily get another 2. And the fact that I had 2 allergies in one trip means really I need to have 4 with me now, just in case I can't top up. But also in many of the countries where I travel, even in Europe, even in Western Europe, the ambulance doesn't always turn up. And so actually be able to make that decision on that 3rd EpiPen, where I know the risk of side effects such as potentially cardiovascular sort of risk can increase, and it's preferable in our country anyway to do it in the ambulance or the hospital. With me, I actually would rather be able to take that decision into my own hands if I need to when I'm on a business trip, but obviously always I will wait for the ambulance. But three key points I want to come to, and I think just one last sort of life lesson I think from the tree nut perspective is the rise of vegan options, vegetarian, sustainable, conscious diets has actually seen a real increase in nuts in the food system, and that's quite a terrifying thing. That what used to be quite a rare thing to have an accidental stumble upon with tree nuts is now actually very common, and that's because of the fact that nuts are a very good protein for those aren't eating meat. It's been put into a lot more things like smoothies, which means you get risk of contamination in things like blenders. So there's been a real rise, not just in people with allergies, but in actually the prevalence of a very serious allergen in tree nuts and also peanuts. But look, the 3 things I want to focus on in terms of unsticking the system at scale is language and cultural as number 1. The second one is that surprising gap in workplace health and safety. And I think this is a really big one, which I spotted following that reaction on a business trip recently. And then the third is access to treatment. And if I just take them in quick succession, what I've noticed in my travels, in my communications over the years, is that there is a real challenge with communication between the person who has an allergy and those that are trying to help you, whether that be in the restaurant or whatever that might be. And that isn't just when you travel abroad from a language perspective, it's also language within English. And that's where the things like may contain, can't guarantee, I'm okay as long as it's not in the recipe or the ingredients, but we can't guarantee there aren't traces in this. And that whole piece needs some form of policy guidance to really help both parties who both mean well. We're trying to raise the fact that we've got an allergy, the restaurant's trying to make sure they don't cause us harm, because that works from a food poisoning perspective. We don't go to restaurants and say, hey, can we just check that you're not going to food poison us? And they turn around and say, well, we can't guarantee that. It works. And the principles of separating equipment, making sure it's washed properly, thinking meat, veg, chopping boards, they work very well for food poisoning. There's no reason it can't work for allergens that are life-threatening and cause anaphylaxis. And so there's an issue within English, but there's also an issue when you travel. There are many countries which don't have the same prevalence of allergens that we have in the UK, which means culturally they're even further behind us. And so there's an element of that, but there's also an element of language where something like a nut is a very well-known collective noun in English, but it doesn't exist as a collective noun in other languages, which means you sometimes have to explicitly state each individual allergen within what might seem like an obvious group for us in the UK. So I think there's a lot of work there that we can do on helping people have that conversation in a way that works across cultures, across language borders, but also across legislative risk. Really a lot of that can't guarantee in our culture comes from people not wanting to be sued. And so again, we need to help both sides transact in a language perspective in a kind of safe way. The second thing is that gap in health and safety policy. And really what I realized when I was traveling in France is there's no policy in health and safety in any workplace, whether they be restaurants, airplanes, offices, for people with life-threatening anaphylaxis. And that's something which I'm working on now with Anaphylaxis UK, and we're looking at trying to pilot. But that's a gap that really needs to be filled. How do we handle people who are traveling on business trips that have life-threatening allergies? How do we handle people visiting our offices when we're feeding them lunch or whatever it might be, to make sure we've asked in advance? How do HR teams make sure they know who have these conditions up front, like they would other health conditions? And many people will not admit to having an allergy in their HR onboarding forms, but they would admit to having something like heart conditions or diabetes, because for some reason allergens aren't always seen as a medical condition, because they're not, otherwise you're healthy unless you're exposed to the allergen. So workplace health and safety is almost a catch-all. If we can plug that gap, similar to what Anaphylaxis UK are doing with schools at the moment, you really do fix everything, because suddenly we have a way to work together where everyone knows what they can and can't do, and we have policies and processes which people can follow. And it's a real gap which needs to be filled. And then lastly, it's that access to treatment. And what's terrifying is, when I was younger, there wasn't treatment like oral immunotherapy and things like that, which there are now. And the options are there. And from what I understand with things like peanut allergies and palforzia, you can have something like an 8-week treatment where by the end of it, as long as you keep a maintenance dose of potentially even having an actual peanut on a sort of weekly, every other day basis, whatever the sort of prescribed amount is, you actually, to some extent, have cured the life-threatening piece, and you've moved into inconvenience territory, which is a huge, huge shift. But the challenge here is that the NICE guidelines haven't kept pace with that evolution of science and the treatment, which means that those who do have private healthcare, or lucky enough to have private healthcare, aren't able to get that treatment, which means they are forced to then turn to the NHS. The NHS has very few allergy clinics, which means they have these huge long waits. And in my experience for my son, it's been nearly a year. And even when you get through the food challenges, it's not guaranteed that you're going to get to oral immunotherapy or a palforzia type treatment at the end. So there's a real thing where if we can update those NICE guides to reassure the private world that actually this is a treatment, there is a way which we can take people from life-threatening to inconvenience, and that is a simple 8-week thing, and then that has been paid and done. There are huge amounts of people that could go down that route, freeing up some of those waiting lists in the NHS, but also hopefully encouraging the business case for other drugs, maybe more generic ones that don't carry the same cost as things like palforzia. So I think that's another big thing, is that access to treatment. And some of that is as simple as tweaking documents like the NICE guidelines. So I'll finish because I know I'm over time, but living with anaphylaxis, it really is much more than just personal vigilance. I've done that for years, and I'm getting caught out more and more these days because things are becoming more complex. Allergens are more prevalent than they used to be. We eat more complicated foods than we used to. It's almost that simple. There's a big thing around that language, the cultural piece, the access to the treatment, but also workplace policy. And as Elia said as well, this is a big change. It's policy reform, it's societal understanding, and genuinely this is a fixable thing. Like with sustainability, my day job, this isn't a science or engineering problem. We know the answers in many cases. This is a how do we actually unstick the people problems, the bureaucracy, the administration, etc., and actually get this working properly. So I'll pause there because I know we've got Q&A coming, but hopefully a good summary and some sensible signposting.
Great, thank you ever so much, Robbie. Now I'm going to resist the temptation to carry on chairing the sessions, and I'm going to hand it over to Louise. Before we do so, Louise, I wonder if behind you might mind closing that. It's
Sorry.
just with the light, so it just means that we can only see a bit of a silhouette of you. There we are. It's just the lighting and strangeness of these sort of cameras. See if that makes a bit an improvement. And Robbie, just before we go, this morning Professor Adam Fox was talking through all of the exciting medications and treatment options that were coming. One thing that struck me, and we've talked about this before, is the wait to get onto those treatments you mentioned there. And we've been talking about, a couple of years or a long wait. Adam this morning was talking about a 25-year wait to get onto some treatments. Quite shocking.
Yeah.
Louise, forgive me. Over to you. Louise Wilkinson, one of our trustees, a fabulous person that puts an awful lot of work into the charity.
Thanks, Simon. Sorry about the light. It's a shame, isn't it, to block out the sun? But yeah. So thanks for having me. Yeah, as Simon said, I'm one of the board members for Anaphylaxis UK, and it's a real pleasure to be here listening to everybody. I myself have got a teenage daughter with allergies to milk and nuts, so it was really interesting to hear your talk, Elia. And there's lots of enthusiasm and gratitude in the chat for all of your presentation. So thank you for that. I've just picked out some of the main questions that have appeared in the chat. Firstly, Maya says, if someone has anaphylaxis and isn't previously diagnosed with allergies, how would you manage the situation while waiting for help, particularly if you don't have EpiPens? That might be one for Hazel. If you're still there, Hazel, I can't see you. Oh, it doesn't look like Hazel's still there. Perhaps I'll move.
I don't know if Hazel's still there, but I just wonder from Robbie and Elia, you know, there is a long wait, we know, between both seeing a GP, but also getting to an allergy clinic. Certainly at Anaphylaxis UK, we do our best to try and provide that bridge, providing information, giving the support for people in the information that we can provide them. But what mechanisms, what tools do you also turn to? How do you manage that kind of gap between your contact with healthcare professionals? Clearly, over time, it'll evolve, it'll improve. But what tips would you give to those that are listening?
Okay. Hi, Simon. So I do subscribe to something called FeedSpot, which gives you news updates. It's quite interesting because it's a worldwide network. I also check the Food Standard Agency resources. They have an amazing free online food allergy training, which gave me a great understanding of how to prepare food safely and labels. So, and obviously, as you say, Anaphylaxis UK, the VSACI websites, those are really trustable sources of information that I regularly consult.
Thank you, Elia. I had a question, if that's all right to ask. You talked about your son and the role of his friends, and I loved that you were saying about sending snacks that they could all share, which is just a really inclusive approach to that. Some of our really good friends have asked me the question, what can we do to support you best? And I just wondered if you'd be happy to kind of share anything that you've had that's been really positive and good support that we can share with everyone.
Okay, in all sincerity, I rather provide my own food because I cannot expect other people to learn everything I have learned, especially with a milk allergy. But what is important is to share the information. You know, it's lovely when they all know that Eddie is that all know his allergies and make sure that the food in the table is presented in a way that he is not threatened by, because sometimes you can feel a bit nervous. I have had actually occasions where I've been really moved by what people have done. Once Eddie went to a party and the host, without telling me, literally bought a dairy-free cake for the whole party. So that way, for the first time ever, Eddie could eat the dairy-free cake, you know, and share it with everybody else. And nobody noticed. nobody noticed that it was different. Also, sometimes when there are picnics and people say, oh my God, I really feel a bit nervous about providing something, but can I buy something? I say, yeah, well, there is a dairy-free chocolate that Eddie likes, and then they bring something small for Eddie to feel included. And I have a man who literally prepared a dessert of jelly with loads of fruit. And that was obviously completely safe. So yes, his friends especially, they are advocates for Eddie. I have seen when they were in a table once, the food was coming. And that's when mistakes can happen when serving too. And all the friends were, excuse me, is that dairy free? Is that dairy free? And it was so lovely to see how other people support. So I think communication is amazing. And obviously, keeping those good friends next to you.
Oh, that's lovely to hear, Elia. Thank you so much for that. Can I just ask another question, which is the opposite of that? Have you got any advice on kind of how to handle bullying or people who aren't perhaps as helpful as that?
Well, I think the role of the school is pivotal. They set the example. So in his school, they share Eddie's allergies. They also spoke about the impact of allergies to the children. I know they have reached to Anaphylaxis UK for awareness too. We have had occasions when people haven't been kind, of course. You know what? It's true. It can bother you. And I think resources like having access to mental health support, it is important too. That's helpful. I think what Eddie likes is also building his own confidence. It helped him being good at music, and I think every child has a gift, and if you can yourself feel strong, I am valuable, no matter what you say. I am important. I am my life has value. So whatever you say, I don't care. So I will say embrace that, encourage your children to follow their passions, whatever they are.
Oh, thank you, Elia. Hazel, I can see your back. I think there's a question that you might be the best place to answer. Nikki has asked, regarding food challenges, what are the restrictions for carrying those out? Do skin prick tests and blood work need to be a certain size and amount, I guess, to trigger that?
Well, you have to remember that I'm not clinically trained. I'm not a medic. So I'm not qualified to talk about medical things. I think you need to ask maybe Helen or one of the other medics.
Louis, can I go back to the previous question about bullying?
All right.
And I'm just asking about with Robbie on the call here. Just in bullying in the workplace, it might not be necessarily, how we might imagine bullying.
Well, I was going to
Remembering
say on that subject, in a previous life, I was a long time ago a school teacher, and I've had a nut allergy since the 60s, so a long time. And as a school teacher, especially with teenagers, I was very upfront about my allergy, and it was not that common. But of course, children are children, and I had my year 10s, and they carefully left me a Snickers on the table. Okay, it was wrapped. And then another class of unruly hooligans left me a drawer full of pistachios one day, all broken up and in shells. So, I mean, it's sort of bullying, but it's also sort of experimental and a bit sort of like scientific, and it's also challenging, obviously, the teachers. So, yeah, you have to deal with it. You have to face it and accept that that might be a thing, and it's hard. But as a teacher, it wasn't that hard, and I was very public about my allergy. But I think for kids, we have to recognize that this is something we need to really keep on top of.
Robbie, how do you feel about it in the workplace? I mean, not necessarily bullying, but when you've you've got a colleague who's either retiring or, even if you're just having a social event and you're popping out for the restaurant or popping down the pub maybe on a Friday afternoon, but then not necessarily feeling as though you have the confidence to go and stepping out.
I mean, it's a real nightmare with work events. I mean, literally just before this, I was having to. I'm speaking at an event tomorrow morning, and again, I won't name any names, but I can't get them to even sort of confirm that they've not prepared it without nuts in the ingredients. They just, all you get is we can't guarantee, and almost because of two things, because of that, the whole we can't guarantee unhelpful response, which just causes everyone a kind of stalemate situation and creates admin effectively, because we then have to work out, well, what do we do? Does Robbie go off and buy his own food? Do I prepare my own stuff, etc.? But also I think the complication between the very large group of people with food intolerances, and to some extent beyond that, food preferences, getting even softer, but those who have immediate, if they don't have urgent medical treatment within sort of 15 minutes to half an hour, they've got a life or death situation, does also confuse the conversation. And that's where I think in the workplace some of the jokes come in, because people mistake having a life-threatening anaphylaxis reaction to someone who might be either fussy on something or has a genuine food intolerance, but isn't something which is life-threatening. I think not being able to separate the two makes it quite different. And I think if we're very clear that this is life or death, it is literally a food poisoning within the moment, I think there wouldn't be any bullying or jokes about it. To Hazel's comments, I think probably it's with the kids, it's a misunderstanding. But I think that wider bit around when you get the pushback, can't guarantee it just causes administration problems, and that's when people start to get a bit like a bit sort of jokey about it, and Robbie's an inconvenience because they can never give us a straight answer. It's always we're always having to compromise. But I think similar to Elia's comments, I've been really touched by a few work events I've been to where they've actually just gone, do you know what? We've got someone with a life-threatening allergy here. Let's just make the whole menu nut-free. Like, people can survive one meal without tree nuts. And that's an incredibly nice thing to do, and not an inconvenience really to anyone going. And it's quite probably rare statistically that you do have someone with a life-threatening allergy. But if you can separate those out from the intolerances, that conversation becomes much easier. By the way, I'm not saying intolerances aren't important, just it's a different conversation.
Thanks, Robbie. Yeah, I think, I mean, from my own experience, my daughter, when she did her Duke of Edinburgh Award, the whole group just went dairy-free and nut-free, which I thought for a group of 14-year-old, in that environment is really impressive. So people can be really impressive. But I think one of the key things is the media doesn't really help in the way that the allergy kid is portrayed as somebody that can have, fun / bullying, to, Mickey taken out of them. I've had a question while you're on, Robbie, which is from Sarah, which you may or may not be able to answer, but talk about do employers need to be better educated? Do you feel that we should have better equality and employment laws to protect employees?
I mean, I'm a huge advocate, as I said, I'm in sustainability, and I joined where I did because of the fact I can impact so many businesses in a positive way. So I'm a big believer that if you can redirect business, and to some extent I would put schools as a business as well, but I appreciate that's happening as a separate conversation. But if you can fix business, you almost fix everything, right? Because restaurants are businesses. So if restaurants have proper policies on life-threatening anaphylaxis, by default, you're protecting anyone who dines at that restaurant or shops from that shop. If you get it right for businesses, airlines are businesses, trains are businesses, lawyers, offices, all these sorts of things. And if we can get workplace health and safety right, and obviously put in the various adjustments for each of the different sectors, then it becomes really powerful. Most of us don't have EpiPens in our health first aid kits. Most of us have, don't understand that there's legal protections if you were to take steps to save someone's life in the workplace. So actually what I see is a lot of, I don't want to give someone an EpiPen in case I get some type of legal repercussions. And so if we can really help to educate and stick that into workplace policy, it really does change everything across the whole economy. So that's why I'm so passionate about working on this with Anaphylaxis UK. That's why I did the London Marathon, helping to raise funds, to help, to hopefully, channel some of that into that work stream going forwards. And really, it's building on the great work they've already done with schools.
Can I add to that? Because what Robbie says is so important. I think the quality, it is true. The conversation about allergies being a disability is well behind here. In the US, is very well recognized by institutions and schools that allergies can be considered a disability, especially when they are life-threatening. And so the Quality Act really clicks here. And one of the important things that they say is that in order to make everybody equal, you have to treat some people different. And these are the people who need help. I will say that if, for example, with my son, we have always talked about assertiveness. So it's not only about saying when he goes out in a restaurant, for example, and some of his friends suggest a restaurant that he doesn't feel safe with, he will say, okay, look, I really cannot go to the restaurant, but he also recognizes that his friends will be disappointed. So he will say, I'm sorry, I know this will. So we tell him, you do say, I'm sorry, I know you will be disappointed by not going to that restaurant, but if you all choose to go there, I will not be able to join you. And that makes the difference for the friends too. So it is. I think it's about trusting that people will be kind. For the ones that are not kind, well, it's better not to have them around. That's what I think.
Just one very quick thing to add to that, because I think it's also an important point, is the airline industry, aviation is such a safe industry because they learn from their mistakes. It's that black box thinking mentality. And with so many people now, doing things like we're doing just now today, sharing their experience of where they got caught out and then bringing that back to update the policy, that feedback loop is one of the most important things when you have somewhere for it to land. And if I'm very good at navigating my allergies, and it's very hard as a kid. Having a child that has it's hard because you have to do it for them, but I get caught out. And each time I get caught out, it's an unusual circumstance I couldn't have anticipated. And if we kind of have a mechanism to all feed that back, we will make it safer and safer with each exposure. And I think that's another really important point to make with the workplace policy and also the schools policies as well.
And go on, hey, I talk enough.
Would I be able to add something on that? Sorry, it's just that the ability to do risk assessment in different scenarios, and I know risk assessment is a very sort of businessy, technologically kind of thought, but that's what we're doing all the time. And if we had more environments where it was more standard and you could just negotiate, get alongside people and talk about what kind of things might happen and what could you do about it. And I think one of the most important ones is for catering, which is that there's a lot of stuff that's already going on. I mean, I train caterers, I have done for a long time. And if you talk to them about, well, do you wash your hands? Well, yes, I do. Well, that's an allergen control. Oh, is it? Okay, well, that's good because I don't have to do any more work and I can get a benefit for the hypersensitive people as well as everybody else. And there's a lot of other stuff that goes on in catering. So rather than this kind of lockjam of despair, which is, oh, we can't help you and you can't eat our food, let's start by what you're already doing. You're doing segregation, you've got your stuff in the cupboards that's well packed up and it's labeled and you've got information about it and you're managing the information. So you look at what they're doing already and you make it the positive out of that. And you say, so when I come and I tell you I've got this particular issue, what else can you do? And you may still end up with a moment where you say, look, it's really not safe. There's so much milk powder around in this coffee shop that I'm not going to be able to have anything. But maybe you can. So start with what they're doing already for everybody as a general control, which is beneficial to people with food hypersensitivity. And then add on, in my case, would you be able to rinse the plate and the cutlery? Would you be able to use a clean pan? Would you be able to start from scratch? Would you have a new pot of jam so I don't have to use the one that everybody else has used? Those kind of simple things can be very helpful and can, if you've got the time and the motivation, can be fabulous to discuss and work out.
And I'll just add as well to that, Hazel, it makes it a nicer experience. And that's most of the time you want to go out to a restaurant and have a good time. You eat good food. is very important, obviously, but so's the company that you're in and how you're greeted. And still we hear too often about customers having to sign waivers or wait for the allergen champion or the work manager, or being given a wad of menus going back the last 10 years just so that they're covering everything. That's too common, isn't it? And certainly some of the work that we're doing with lots of the businesses is to see how can we encourage that positive experience. How can they positively welcome someone with an allergy, because they know that they're confident in the training that they've given their waiting staff and the procedures that goes in the kitchen. So it's not just about, the kind of sharp end around anaphylaxis. It's what goes with it. It's that living every day with it and not being singled out. Who's the one with the allergy on this table? Who's got the nuts? It's not doing that and putting somebody in a situation that is embarrassing or awkward or singling them out. People don't, in my experience, most of the time with those restaurants, they're not doing it out of maliciousness. They're not doing it on purpose. They just don't know. They don't realize how awkward, how awful, how embarrassing it can make that individual. And when you talk to people, generally speaking, they want to be nice. They're in the hospitality business. They want to be hospitable and welcoming. And it's just a matter of letting people know, well, actually, you're putting that label on a packet for good reason. Very often, sometimes they're covering the back. Sometimes they think they're doing people with an allergy a favour by having it on there, and actually not realising what it means. Or if they're saying, sign this waiver, they think they're doing a good thing and making sure that that person is actually safe, but they don't realise what it actually means and how it makes somebody feel. And just having that conversation with businesses, I think, is very important. You've done a lot of work in this space as well, Hazel.
Yeah, you're absolutely right, Sam. And in our experience as well, it's the difference between being welcomed in and someone confidently taking you calmly through their processes, what they do that kind of shows you what they're doing, as opposed to someone saying, we can't guarantee anything. It's the difference between a pleasant family meal and and one where everybody's on, tenterhooks waiting for something to happen and feeling on edge. So yes, there's quite a lot to learn in that area. Elia, did you have anything you wanted to share about how you approach those, as you come into a restaurant, the key questions to ask, or Hazel?
Oh, I just wanted to reinforce what Robbie said about feedback. I think most of the restaurants, as you say, are really willing to improve and help and provide the best experience possible. But yes, there are cases, and we have seen them. There are cases when there are safety risks. I have heard many people just telling me how angry they get in the restaurants, and I say, no, don't. If you have such safety concerns, you need to report them to trading standards, because you may think just leave. You may think this happened to you, but and you were a lucky one, but the next one may not be lucky. So I don't think we should shy of reporting these risks. I actually have a very bad experience in a restaurant. Not my son. I was ordering at the till because this restaurant has this policy for people with allergies. And somebody behind me became a bit impatient, because obviously the manager was checking all allergens with me, and began to say, oh, hurry up, and all sorts of abuse. And the manager said, please, be patient. We have somebody with allergies here. And he said, well, if they have allergies, why they are here? Why they are eating out? They should be at home. They shouldn't go to restaurants. It was awful. So awful that I literally report him to the police. I reported it as a hate crime because of a disability. And the manager at this restaurant supported me. The police took me seriously. And I hope that person now won't do that again to anybody. So I think there are little things that we can all do to make this the world more understanding and, you know, to educate everybody.
Thank you, Elia. That's really brave, I think, to report that. I know we've definitely come close to where you're saying actually what you're talking about is threatening someone to kill somebody if you carry on with this level. Yeah, and we've said that to school. So I think everyone's probably experienced that to some extent, sadly. So huge thanks to Hazel, Elia, and to Robbie for excellent presentations. So we're going to have a break now. We're back at 2:50. Tell me if that's wrong. So, no, he's nodding, so that's right. 2:50, so that should give everyone time for a cup of tea and a leg stretch. And then we're back for 3 more presentations on allergies in schools from both the parent and teacher and school nurse perspective. So yeah, if everyone wants to go and take a quick break, we'll see you again at 2:50. Thank you.
Thank you.
Thanks, everyone.
So welcome back, everybody. Thank you so much for joining us again. Are we back on? We've got 3 talks now focused on allergies in schools from the parents and teacher perspectives. So the first person who's ready to speak is Taj Randhawa. Taj is one of our board members at Anaphylaxis UK, and she's put loads of work in over the years to support us. She brings a wealth of skills from business and marketing to the board, and she also has a daughter with severe allergies and has worked with Anaphylaxis UK along that journey. So I'll hand over to you, Taj.
Hi, I hope you're all well. So I'll talk a little bit more about my experience as a parent, but also focus more in on how I've tried to help my daughter navigate school. So as we said, I'm a trustee for Anaphylaxis UK. I am also the mother of a teenage daughter who at one stage had allergies in the double digits. And now I say only, but still, whether it's 1, 2, 3, or 100, it's still the same amount of stress, which is managing nuts, sesame as her main ones. And she's currently undertaking immunotherapy to milk. And I'll be honest, I never encountered allergies before my daughter was diagnosed. And even now, it feels really surreal when I look back to those early days. Where I had no clue why she was being ill after eating certain food. And if you think about the number of allergies she had when she was young, she would react with me, she'd react with her grandparents, she'd react with her nursery. And it took a good few years before I was in a place to be able to truly know what's going on and to be able to advocate for her. So I think what's been really interesting today is if you kind of think my daughter is now 13, though she probably thinks she's 18, all those years ago, the treatment plan and the advice that we were given is completely different to what we have now. So it was a real gradual build up before my daughter was fully diagnosed with her allergies. And our doctors were amazing, but I entered the world of skin prick tests, blood tests, the link with eczema and asthma, and they're all new to me. And I'm the type of person, I'm used to having a headache, taking a paracetamol, and it fixes it all. And here I am learning on the job. So my natural place was, right, so why has this happened? And when the answer comes back as, we just don't know, I thought to myself, we can send a man to the moon, but you can't tell me why this has happened. Why, as a parent, what have I done wrong? And I think those kind of questions still go around my head sometimes now, but they were definitely really loud when she was young. And in terms of journey I took, I read every book, every paper, and every theory I could get my hands on, and not all of them were legit, to understand the why. And then I started moving on to finding a cure, which if you think about it now is quite laughable. But I was on a mission to fix her before she started school, because I felt as soon as she goes to school, I'm not going to be able to protect her. And I do remember once she was diagnosed and once we sat in that doctor's chair and then they told me that she has got loads of allergies, it felt really overwhelming. So suddenly everyday things like birthday cakes, school lunches, play dates, they started carrying a weight they probably never had before. So I think when it came for her to start school, I was probably more nervous than she was. So when I'm sending her through those school gates, it really for me meant trusting other people to keep her safe. It meant extra meetings with teachers, making sure everyone knew what she could and couldn't eat, and double checking that an emergency plan was in place. But it also meant talking to a 5-year-old about understanding her body and how to speak up and how to never feel embarrassed about asking what's in this. And what you have to remember is we're learning as we're going. We didn't know it all. So my daughter is 13 now. What we know now, we know so much more than when she was a 5-year-old. And even today, I've learned so much more. And if you think about this, we're going through this journey every single day. And if I'm in a position where I'm saying I'm learning something new, it just tells you how fast this field moves. So if you think about it, I waved her off on her first day with her little badge which said, I have allergies, pushed her in and praying that she would be okay. So the school itself, they were great. They sat and spoke to me, showed me her classroom where her EpiPen would be stored, let me send her in with snacks she could have, but that didn't stop the mishaps happening along the way. So the spilt milk from a classmate, which caused hives, the playing with lentils, which caused her eyes and her face to swell up, and the classmate who brought in Nutella and didn't know they had nuts in it. So I am never far from the phone. And so when the school name pops up on my screen, the first question that comes out of my mouth is, what's happened? Is she okay? And not every teacher is consistent. So I have had to go in every new school term, every time there's a new teacher, every time she comes home and says something that slightly worries me. And over time, it becomes a rehearsed script. So I would ask the school, who's had the EpiPen training? Who's given it? When was it last given? What is the plan should she have a reaction? And in your head, as a parent, you are risk assessing everything and you are playing a virtual video game as to how you're going to mitigate every single possible thing that could happen. And to give you an example, my daughter had a serious allergy at school. And the teacher's advice to her was to go walk down the corridor and go to the nurse's office. And I had to go charging in after the event was over and say, that is not what happens. You go to her. She does not go by herself to the nurse's office because anything could have happened. So during school, her primary school, she had 2 residential trips. And as you can imagine from what you're hearing from me, the minute that an email comes through, like, we'd like to invite your daughter and your child to a school trip away, the dread that creeps in. But I made my husband go with her, and there were 2 reasons for that. One, I needed to start backing off and allow her to start managing her allergies herself, but also start to prepare her for secondary school. And that was a real good eye-opener. So though my husband went, he tried to stand to one side, watch how she navigated herself for when it came to breakfast and lunch. And I think at only one point did he actually intervene. And that was when he realized a caterer was making up what was in the ingredients. And he casually walked over. I showed him a picture of what my daughter looks like when she's having a reaction and said calmly, you get the ingredients wrong on this. This is what happens to her. So let's start this conversation again. So that's not just school, that's wherever we go. And I think we've spoken with some of the other panelists about what happens when you go to restaurants, in the world of work, and all these things that my daughter will have to navigate. She is now at secondary school and she's a very different person to what she was when she started primary school. So she is more aware, a lot more mature. And though I had the same conversation with the secondary school as I did with the primary school, I haven't had it since she has started. And that's because she's grown up. She's become so much aware of her allergies and her reactions. She knows the signs when something is not right. She knows how to use the medication if she needs to. And she's confident normally telling an adult straight away. So that awareness and her courage, it gives me comfort and pride in equal measure. But as a parent and knowing what teenagers are like, my constant worry is about that school bullying, that one child think it's all right, throwing a peanut at her, the social isolation she might feel, and actually how she might navigate certain situations with her friends when they're doing something, want to go somewhere, and it just requires an extra level of thinking for her. School trips are still nerve-wracking. I still pack a bag full of very unhealthy but safe snacks. her medical kit, her action plan, and a slight little quiet prayer that everything will be okay. And today she's at sports day, and though I'm really proud that she is taking part, that little fear in the back of your mind never goes away. But more importantly, and I think we've spoken about this before with some of the panelists, is I know she talks to her friends. She tells them what allergy reaction looks like. She tells them where her EpiPen is. She answers any questions they've had. And she's taken initiative to take them through a trainer pen. So she's told them and she's shown them what they need to do if she was to have a reaction, and how she needs to be sitting down and how they need to call for help. And she's been really clear that it's not a joke. And children normally are amazing. They listen, they learn, they want to help. And I just hope that carries on for her. So secondary school for her is a big step. It's more independence, more social time, more risk, but it's also a chance for her to own her own safety more. So we've had lots of conversations about how she needs to ask questions when she's in the lunch hall, how to read labels, how to remind new teachers about how to keep herself safe. While it's not about wrapping up in cotton wool anymore. It's about equipping her to keep herself safe while still joining with everything her friends are doing. The hospital where she goes to have her immunotherapy is amazing. Every time she goes in, they will quiz her on a number of different scenarios. So she's always owning her allergies. And like I said, every time we get away from there, we've always learned something new, and we're kind of discussing, well, I didn't know that. And now at least we know that. We know, should you ever have a reaction? And for her, she's had numerous food challenges over the years. So every time she has a reaction, she learns something new about herself. She learns a new feeling, a new element that she needs to be aware of. And I would say the one thing I've learned as I wrap up is that managing allergies, it's never just one conversation, it's many. It's reminding teachers, talking to friends, checking food labels, and teaching my child and any child that their voice matters, that it's okay to speak up. And there is a phrase or something in social media, which is a mother who has a child with allergies is probably akin to someone who works in the FBI, with the amount of investigation that we do to keep our children safe. So I would say thank you for listening, and over to you, Louise.
Oh, thank you so much, Taj. That was fantastic. I absolutely love that FBI analogy. It does always feel like that. It feels like you've got to be like several steps up and several different scenarios ahead of everybody. So yeah, no, that was absolutely brilliant. And your daughter sounds brilliant as well. So we'll go straight on to the next talk, and then we'll do questions and answers at the end of all of that. So our next speaker is Tracy Dunn, who is going to be talking to us about protecting pupils and becoming an allergy aware school. Tracy is the Education and Allergy Wise Manager for Anaphylaxis UK. She's a former head teacher, so what a brilliant set of skills to bring into that role, and is the driving force behind Allergy Wise, and initiated the programme 8 years ago. So thank you. It'll be a real pleasure to listen to you, Tracy. Handing over to you.
Hey, thank you very much. I tell you, it's been an absolutely wonderful day. I've been listening in as I've been doing a few bits and pieces, and it's really empowering to hear about all of the exciting things that are happening with allergy, as much as there are the challenges that are still faced by those living with allergies. So as you said, I am a former executive head teacher, and was the education ambassador for anaphylaxis campaign and then UK while I was in education running allergy aware schools. We made sure that every single one of our children was included and had really positive experiences, and none of the children in my schools have had those experiences as have been described by parents at all, and including my allergic staff, as Robbie was talking about. I had staff members who learnt so much just because they had the good fortune to attend my schools. So it's a real passion of mine, and that passion comes from the fact that I'm a parent to 2 children with allergies. One is now 18 and has simple peanut and kidney bean allergies and carries adrenaline auto-injectors. And the other one is undergoing immunotherapy for severe hay fever and grass and birch pollen allergies. So it's neither of them had their allergies very early, and navigating school has been an interesting lesson for us too. But I'm really lucky to be now in this role where I can help other schools, help their staff understand what they need to be doing to fulfill their legal requirements and to keep children safe in schools. I talk a lot about safer schools and safeguarding. One of the things that is really obvious to me, knowing education inside out and backwards, is just how much allergy management and keeping children safe fits inside the school agenda of safeguarding. And it's not different. And we're keeping children safe from all sorts of harm. We do fire drills to keep them safe from fire, and so they know what to do. And so in its widest context, this is exactly what we need to be doing with allergies for everybody in the school staff, right from the caretaker all the way through to the head teacher and everybody in between. Secondary schools are quite interesting and complex, as are the higher and further education colleges, because they seem to think that only a tiny number of staff actually need to understand about allergies. But we all know that allergy and anaphylaxis can happen to anybody at any time. So therefore, we need to make sure that everybody is empowered with the right information, so that if a child is experiencing an allergic reaction or anaphylaxis, that the history teacher doesn't decide to send them to the office, that actually we know what to do, that we're not reliant on one or two members of staff to actually come to their aid once they've called them on a walkie-talkie or in any other way. So it's really important that a safer school does take that whole school approach, that we have the policy in place that is going to guide the school's work with that support that they need to have and those procedures that they are going to follow. All of that is underpinned through thorough training of absolutely everybody. It's your first aid training just simply isn't enough. On the 1 day first aid at work course, allergies not even mentioned. And on paediatric first aid training, you get a little bit more, but actually often it's on the virtual day rather than the in-person day. On your forest schools or on your 3 day at work course, yes, it's covered a bit more, but I have been working with a number of different organisations where their information that they are sharing about how to administer adrenaline auto-injectors is actually wrong. And so we need to get to a point where everybody understands the right procedures and that their information is kept up to date. Right back at the beginning of today, Adam Fox was talking about the fact that, you know, the way that patient positioning has changed. And unless these companies are updating their information regularly, then they're going to be giving out the wrong information. So it's important that people know that they can come to us for that training that is clinically accurate and up to date. Safer schools also need to have those spare adrenaline auto-injectors, which the MHRA allowed schools to start holding back in 2017. And these are adrenaline auto-injectors that are not on prescription. They are purchased through this dispensation by the MHRA and have been able to, as I say, been able to be purchased since 2017. Trouble is, they're pricey. Adrenaline auto-injectors run in at about £80 to £100 per pen, and they expire. It's fantastic that they expire, but there is that annual ongoing cost. And in a primary school, that's £400 sitting on the shelf. And so there has been a little bit of kickback around, actually, well, we can't afford to hold these because of the cost. It's because of the fact that we are not understanding what a safer school is that it makes it much harder for them to understand. If they were actually put it into the context of safeguarding, then they would be spending the money without question. So we've still got a piece of work to do around making sure that they really understand what their duties are in keeping children safe. So becoming a safer school is to do these things that you can see on the screen. There is a model policy that the Department for Education approved. It was written by ourselves, Allergy UK and the BASCI a number of years ago. Provide training for all staff, and that's where we are ideally placed to support schools and colleges and preschools and nurseries. We've got our wonderful allergy-wise e-learning courses for every sector, including the ballet class, the football club, the rugby club, so all of those things that are happening outside of school. We've also got our wraparound care course, so for the breakfast club and the after school club and the holiday clubs. So we have got bespoke courses for every organisation that needs it. And since I've been on the team, we are now going out and visiting schools. So I will go out and I'll visit schools or universities. I'll go to care homes. Wherever there is a need for training, I will go. And we're able to also offer that work with the children, which is crucial in helping them understand and how to keep each other safe, and will eliminate that bullying when we actually start to understand far more about food allergy. Schools, any organisation with young people in it, needs to have a look at their curriculum, and they need to be thinking, do I have to have that allergen in that curriculum? If I don't need to have that allergen in the curriculum, let's take it out. Let's actually plan ahead for our trips and our residentials and work with those establishments to make sure that everybody is eating exactly the same thing. As Taj said, that is the much better way of doing it. And I've run several residentials where the organisation was so happy to be able to do it that way. So that's the final thing is about the communication, proactive communication with parents and carers. I always tell schools that actually when it comes to allergy, your parent is your expert outside of the medical profession. You need to listen to parents. You need to make them feel heard. You need to listen to the child and understand what they're telling you, because they have had to find out all of the information they need to keep their child safe, often quite rapidly, but certainly ongoing. And so if you plan your trip, or you plan your cooking, or you plan your activity far enough in advance and go out and seek that parent or carer's support at that point in time, you just make your life easier. And I'm very frank with schools about this, that actually, you know, I have been the tiger mum. I have been the right royal pain in the butt that nobody has wanted to see me. You know, I've literally seen them scuttle away as I've approached the building when my children were at school, because it's just like, what's she going to say now? Because I didn't trust them to keep my son safe, because there had been too many mistakes made. So I was on at them all of the time. You don't want that type of relationship with a parent as a teacher or as a head teacher. And actually the way to avoid that is to be proactive in that communication. And we still have so many schools saying that they're nut free. Well, we don't advocate for that. We talk to schools about it. But if they insist that that's what they are going to be, they need to communicate exactly what that means. And we will challenge and provide that challenge and support for them. But that also involves regular communication with their entire community. So moving on to the resources that we have for schools, we have got absolutely everything that schools need and educational establishments need. We have written policies for the early years, for holiday clubs, for those ballet and football club organisations to have specific allergy policies. We have got the training available either online or face-to-face. And we have got a complete range of template letters that enable parents and carers to communicate, that they just pop onto their own headed paper, but actually say the right things. And in that way, together, we can keep children in our schools safe with the right actions that the schools need to take. Now, I quite often speak to parents and carers through our helpline, through our emails, and we tease things out together, and I'll equip them with the questions to go in and ask, or the process within which to talk to the school and to take the information in. And we can help parents and carers actually resolve those issues and create safer spaces for their children's schools. And it's great when we hear the feedback that, you know, that school has stepped up and has changed and has understood. We get nothing but very positive feedback from all of the schools that we work with. And we have been able to instigate change across a wide section of educational establishments, which is what we're here for. So we just want to make sure that everybody knows that they can come to us. And so for that reason, I put up my contact details, and I'm happy to answer questions later when we get to the panel. So thank you.
Oh, thank you so much, Tracy. That was absolutely fantastic. Such an informative presentation. And as a parent myself, I totally relate to their face when they see you coming, or also getting the finger of doom we always used to get at pickup. Can I have a word? Especially if there was baking the next day. But yes, so I always used to feel as though arriving with the care plan, this is what you do in an emergency, was sort of shutting the stable door after the horse has bolted. That what I really wanted to do was to give them something that was like, these are the things you can, these are the things you can do. These are the things we can work together on. And I used to write my own actually, but the allergy wise stuff fills that gap, doesn't it? Which is exactly what we need. So yeah, I'm sure people will have lots of questions for you, Tracy, which we'll come to after our next speaker, who is Julie Critcher from Schools and Public Health Nurses Federation. Julie is professional officer and senior leadership team member of SAFNA, is it? Sorry, this isn't my field of work, but and she's previously been an accident and emergency nurse, a school nurse, and acting clinical need for the service. So she's currently course director for the University Certificate for Community Public Health Nurses. So a real privilege to hear from you, Julie. Thank you so much for joining us, and I will hand over to you.
Thanks, Louise. Thank you for the invite. I'm just going to share a presentation. So thank you so much. My name is Julie Critcher, and I'm a school nurse by background. Historically worked in accident emergency nursing, as Louise kindly said, but through my journey in A&E, I decided there had to be something different out there around early intervention to work with children, young people and families. So I'm just going to talk briefly about what a school nurse is, and then I'm going to talk about what our role is in supporting children, young people and schools with anaphylaxis. And then at the end, I've got a case study just to share, something that I was involved with many years ago, but I'm very proud to say we had a very good outcome for the young person. So it's just a slide briefly around what SAFNA is. So we are a non-affiliated professional organisation, and we're about advancing the health of children and young people through the promotion of excellence in school and public health nursing. And I think with the NHS 10-year plan launching last week, very much around the early intervention and the shift I'm not going to read through this slide because there's a lot of words on this slide, but I think for me it's just about how we really support the school and public health nursing workforce. We also support nurses that work in independent schools as well, and I will touch on that because they are very different roles. But we do some of our work through having webinars, communities of practice, lobbying, and being that professional voice and that advocate for school and public health nursing. Linking and partnering with like-minded organisations as well. It's so important that we work collaboratively to try and ensure that our children and young people are well, fit and healthy and can access education. I think for children and young people with allergies and anaphylaxis, that can be a real challenge. And some of what our last two speakers have mentioned really resonates with me, having been a school nurse for 28 years, around that walking into a school, trying to ensure that education understands the challenges of a parent actually letting go of their child or young person as well. Those first few years in school, and then that transition to secondary school brings its own challenges and its unique issues, as well as our young people move through adolescence. So it's a lot of the organisations that we partner with on this page, but the main one is the Health Conditions in Schools Alliance. It brings together over 25 organisations, charities, healthcare professionals and trade unions. And we're working collaboratively to make sure that children and young people with health conditions get the support they need in school. And currently it's covering England and Wales, but a really powerful charity to be part of. And we're currently doing some lobbying at the moment around SEND provision and allergies as well. But we also link in with the local government association. Mental health obviously can link with children and young people that are living with long-term health conditions as well, around how are they supported with their mental health when you're living with that potential life-limiting illness. So qualified school nurses are registered nurses, and we have additional qualifications in public health nursing. So we're known as SCIFNs, Specialist Community Public Health Nurses, and you become either a school nurse or a health visitor or an occupational health nurse when you've undertaken that training. It's quite intense. It's a PG dip in a year, so it's fast and furious training, but they are already qualified nurses, so it's upskilling those nurses into the field of specialist community public health nursing. We are universally accessible to all school-aged children and young people, so be that in schools, in education, and in community settings. We have a unique pivotal role because we can cross that health, education, community, and home. So there's not many health professionals that can actually walk in a school and provide a service like school nursing can. So that is our unique role, that we can be that conduit, that advocate, that supporter for our children, young people and families that are living with allergies and anaphylaxis. We are about improving health and wellbeing outcomes, reducing inequalities and vulnerabilities, working in partnership with children, young people, with our education colleagues. We are commissioned by Public Health to lead the delivery of the Healthy Child Programme, 5 to 19. And obviously there's a challenge around public health grants have been cut year on year. So that does have an impact on funding for the school nursing services. We take a strengths-based approach around working in partnership with children. And I think when Taj mentioned about being that you are the expert in your child because you've been on that lived journey and that lived experience with them. So schools really embracing that, and Tracy's spoken about that as well, about how it's so important to have those channels of communication open. And definitely when school nursing go in and do any awareness around anaphylaxis, it's definitely one of the messages that we say, your parent, your carer is the main person that understands that child or young person. Just briefly, we do have a workforce crisis. We've had 2 roundtable events that have been hosted by ourselves and the Queen's Nursing Institute and the College of Medicine and Integrated Health. And they were setting out to explain what is the issue and what is the concern. And out of that, we have created a campaign around a school nurse for every school. These 2 working groups identified poor government oversight of the delivery of the Healthy Child Programme, we currently don't really have any mandation. The only mandation is for the National Child Measurement Programme, whereas health visiting colleagues have mandation for 5 contacts in England. I'm just talking purely about England at the moment. As I've mentioned, the public health grant has been cut. And we know our babies, children, young people make up a large proportion of the population, yet expenditure is only 11%. And the challenge for school nursing, again, is we've had this 33% fall in the number of school nurses between 2009 and 2022. I'm just going to briefly talk about, there's a hyperlink there when the slides come out. We undertook an inaugural survey, which was launched last October, about we want to advocate the profession, we want to promote the role of school nursing, think about what about the realities and challenges of school nursing. And our findings were presented in 4 themes. What are the health needs for our school-aged children and young people? How is that being delivered in the current climate? And what are the models of delivery? Who's delivering those services? But also, what can we celebrate and what can we plan? And there's not a wealth of research around school nursing. So again, we're trying to really encourage school nurses to consider that research component of practice. What can we share about what's going really, really well? From that, there's an ongoing petition for school nursing, and we've also got an early days motion tabled. Following that, we're still waiting for more MPs to garner the number, which then mean that gets debated in Parliament. The challenge around numbers is understanding how many school nurses are working in the profession. We are bound by the Nurse and Midwifery Council. In September 23, there were 246 on the third part of the register, but we don't know how many of those are actually practicing as school nurses. So how can school nurses support? I think the biggest challenge is around the workforce. And I did a couple of quick surveys last week, and there is a wide variation of how services are delivered. So in some areas, school nurses may not be involved at all with training around anaphylaxis. Some areas are advising that training is done by a specialist group of nurses, or they're signposted schools to things like Anaphylaxis UK's training. So if you want to find out your local area, what happens, I suggest you Google school nursing for your local area, and you'll then be able to find out what actually has been delivered within that school setting. The document's hyperlinked here is supporting pupils at schools with medical conditions. It was written in 2015, which is a little while ago, but we are aware that that is now going to be refreshed and reviewed, probably in the autumn time. So school nursing services can provide support to that child, that young person, that family, to education colleagues. And the main part with the medical conditions document is that we don't write the healthcare plans. We will facilitate, we will guide, and we will support around healthcare plans. It's down to whoever is prescribing the AAI to be writing that healthcare plan. There's an individual healthcare plan embedded within the supporting pupils at schools with medical conditions document, but the BSACI healthcare plans are excellent because they are dedicated to the AAI, but they've also have one where if a child hasn't got an AAI. The other excellent thing with the BSACI is it has the indemnity clause around using that spare AAI that Tracy spoke about in her presentation as well. So the BSACI ones are really, really useful. We can raise awareness within schools, can undertake assemblies. We might go in and provide support within the classroom setting. Individual healthcare plans, as I've already mentioned, really, really important. So I urge anybody that's prescribing the AAI to please provide the IHCP, because it makes it quite difficult for education to then try and facilitate getting hold of that. So I'd say a really, really important part is to make sure that IHCP is written at the point when it is actually prescribed. Advocacy role, we could be supporting the guidance is that children and young people should have 2 adrenal auto-injectors at all times. And sometimes it's really helpful to actually have 2 on the school site, because it could become really difficult taking those backwards and forwards when you're travelling and moving around. So school nurses could provide an advocacy role around writing to the GP, whoever has prescribed that, saying, can we please have 2 more, so we can have a pack on site for school as well. So this is just nurses working in independent schools. They may not be SCIFANs as per se, but they're qualified nurses working in an independent school setting. So they may offer the face-to-face training. They may offer terminally allergy drills. Again, like a SCIFAN, they would facilitate the IHCP. And a colleague that I've got working in one area is also looking at a pupil education programme. I know that I'm right at the end of my time, so I'm just going to share with you a case study. This is a young person I was involved with over a period of time. She was allergic to peanuts, nuts, latex, bananas, cherries, and pollens, and she also had the allergic triad. I met the family at a new parent session, which worked really well, because if schools host new parent sessions, you can actually flag that before the child starts school, that we need a care plan in place for that child to start school. She transitioned into primary school quite well. They went on a residential trip abroad in year 6, so I guided them to think about bedding, taking her own bedding to make sure she didn't trigger any eczema while she was out there. We also talked about having ensured they had a letter to take out the country with the AAIs, and also translation cards. The young person transitioned into one of my secondary schools, and I went in and did some training before she transitioned to make sure we had a seamless transition. However, within the first few months of transitioning to secondary school, she did need to use an AAI on 2 occasions. And some of that, we think, was around the school had a lot of decorating done over the summer holidays. Latex was one of her allergens, and that can be in many, many parts of a school environment. But also just that transitioning, I think the first speaker again spoke about the risk of nuts and peanuts and children and young people in classrooms in secondary schools is very different to a primary school setting. We actually also set up a buddy system for her. We also set up a allergy aware area in the food tech in the school. And like Tracy said, I think in school nursing, we can also be the one that can sort of almost challenge that no nut policy in a school. Is that safe to actually say that? So again, school nursing could be supporting schools to be thinking about their environments and how safe are those environments. The school also allowed latex balloons to come in for children's birthdays. That was stopped and it went to helium balloons. So really, as Tracy spoke about earlier, thinking about that whole school environment. How can we ensure our children and young people are safe within that school environment? So the orange area in the food tech room became this allergy aware area. So everything stayed in that orange zone. That didn't go out of the orange zone. That linked in with anaphylaxis UK's colour at that time. So just trying to make children and young people feel safe in their environment, and hoping to possibly stop any allergic reactions occurring. I also managed to link up 2 mothers in the local area. That's the joy of being a school nurse, working across many schools. Both the young people had latex allergies, so I managed to link them up and they became a support system for each other. And Mother nominated me, I'm very proud to say, for a Well Child Award. It was many years ago, but very proud to have received a Best Community Practitioner for the work. And I think if a service is well resourced, and training is done well, school nursing can definitely have a very, very powerful part of children and young people that are living with anaphylaxis and working in collaboration with our school partners. Thank you for listening.
Julie, awesome.
Thank you.
Oh, thank you. Thank you very much, Julie. Sorry, you can get double thanks and congratulations on your award. That's so nice, because from my own experience, it's things like that that just make the biggest difference for children. And I think, you know, my own experience is individual teachers kind of going the extra mile. You know, one of my children's teachers, he did a baking, and we brought in the baking for everybody so that all the ingredients so everyone could do it. But having that systemically done through safe areas and things like that, that makes it more normal for the child, and they don't feel like, you know, you don't always want your mum to have to be involved with everything. So yeah, that was a really, really interesting talk, so thank you ever so much. There's a question in the chat from Kirsty asking whether school nurses work with homeschool children or just at schools.
It will depend on the commissioning arrangement. but most areas do offer some service to children that aren't in education. The Healthy Child programme is around school-aged children, young people, whether they're accessing education or not. But again, it will depend on commissioning arrangements.
Thank you, Julie. Just a question really about everybody's talking about the 10-year plan. I just wondered, do you think that will have a significant impact on the school nursing and allergy?
We're still working through it at the moment because it's quite a large document. But I do think that shift, hopefully, to sort of moving away into that early intervention. I think it's with school nursing, it's so much around that commissioning and the funding. So it'll be interesting to see moving forward, and the hubs that are going to be. I mean, the hubs are already there in some way, but it's about bringing more practitioners into those health and wellbeing hubs as well. So I think we're on a journey, Louise. It'll be interesting to see where it ends up.
Yeah, I mean, as I said, health isn't really my normal area of work, but just looking at it very briefly from the outside, just looking at things like early intervention and that sort of thing, that looked quite promising. But yeah, no, thank you very much for that. That was great. Have you got any resources or anything that you would recommend any allergy parents kind of go on and read? I guess that's a question to everybody, Julie, Tracy, or Taj, really. And I think in particular that you've sort of read and thought, oh, that's something that other people would benefit from.
We've got so many resources on the website for schools that parents can just parents can have a look at that, and they can signpost the schools for that. But we've also got resources for parents on there as well. So would definitely recommend checking out the Safer Schools programme within the education section on the website, and also the full childcare section too, because that's where the guidance is for those organisations where children might go outside of school time.
And just on
Can I also, Louise, just plug as well, because I know that Tracy was a bit too shy to do so. Again, those podcasts, there's a number of podcasts that Tracy's done with other teachers and parents going through this in some more detail. And again, they're all on Spotify and similar sorts of channels to listen to.
Oh, thank you, Simon. And I think that's really important. I think it was Tracy who said it. I can't remember. It was Tracy or Julie, but someone was talking about sharing and celebrating the good and the positive stories that we can learn from. I often feel like we're so much in the space of not doing that. Actually, it's really nice to be able to communicate, this is how we made it work somewhere else. I think we were blessed to have such a great primary school that actually it made it easier to go to secondary school, because our daughter had high expectations of what should happen to keep her safe. So a question to Tracy. You were talking about other after school organisations. Is there something there? I missed it if you said it. Was there something there for Scouts and Brownies? Because they often have food related things. That's sort of where a lot of problems have lain for us.
Absolutely, there is. So we have a course which is called for clubs and youth organisations, which is perfect for Scouts and for Brownies, and leaders can undertake that course. Then there is, in the free downloads, there is a policy and a risk assessment that leaders can use as well. So the information is there for them. They just need to go onto the website. As I say, the course, tiny little bit of money to pay for that. It's such good value for money considering what they get for it. And then the other resources are all free to download.
Thank you. I know our experience with Scouts and that sort of thing is they're really good at risk assessment because they do quite risky things, and they're quite good at first aid, but there seemed to be a real gap around food. So yeah, that's a brilliant gap to plug. Just while you're on, Tracy, can you explain a bit more for anyone who doesn't sort of understand the positioning on this? Because I think sometimes people are a bit surprised when we say that we don't advocate for schools to be nut-free schools. Can you explain a bit more about that sort of position?
Yeah, absolutely. So into the helpline, we get so many calls from parents who say their school is nut-free and this has happened or that has happened and their child has had a reaction. We get schools will have nuts throughout the school on people's hand cream, in staff's body washes, in the oils that are used in the staff room, on the cakes and in the celebrations tub. They can't truly say that they are nut free. So that's just that in a nutshell. But they also can't manage how what the children have eaten or the staff have eaten before they come into school in the morning, what traces are still on the hands. They cannot police every single lunchbox every day. It's just impractical. So lots of schools say we're nut free, thinking that nuts are the most dangerous thing in the entire world, that by eliminating them, that means there can't be any reactions, which then means they don't need to do training, they don't need to have a policy, and there is a high level of complacency. So therefore, we see more incidents happening in a nut-free school than in a school that has adopted an allergy-aware approach, where an allergy-aware school will maintain it can happen here. They will have the policy, they will have the training, they will have the practices in place that will keep the children safe. Then what do you do if you've eliminated nuts and then another child comes in and they have an egg allergy, and a different child has a milk allergy, and a different child has a sesame allergy? Are we going to eliminate all of those? Well, we can't do that. So then you've got an act of discrimination happening, because you are potentially, in theory, we know they're not meeting the needs of the child with a nut allergy, but you're discriminating against the others. So you've got some active discrimination going on. And then also, what about the child that has multiple food allergies themselves? Why would they only pick on one of those things to eliminate? So actually, it's not about saying, oh, we're just going to just do nothing about allergies. It's actually saying we are going to be stronger than you can possibly imagine in protecting our children with allergies if we are allergy aware as opposed to nut free. Does that help?
Yeah, that really helps. I think, I mean, it's certainly been our experience. It's kind of almost a false sense of security where the teacher's like, well, it's a nut-free school, but actually the reality is that if your child doesn't have nut allergies, even really close friends of ours will be, they'll send their kid in with pesto or, things, because you don't check if you don't have to. And I wouldn't, you can't expect people to. So no, that's really, really helpful. And just finally, you were talking about the extra adrenaline auto injectors that aren't the ones that the kids are carrying or been prescribed for themselves. How would a school go and get how would they get them?
So what they would do is they would use a template letter. So there is one on our website in the free downloads, and they would put that onto their headed paper. The head teacher would sign it, and then they would either take it into their local pharmacy or go on to one of the online pharmacies. They'll have their quick consultation, pay their money, and hey presto, they have got their spare adrenaline auto-injectors. And these can be used on any child with a known allergy or anybody experiencing anaphylaxis for the first time. With 20% of food allergic reactions happening in school in children with no known history of allergy, I can't recommend it highly enough that schools hold these, because they literally are life-saving medication.
Yeah, no, thank you very much for that.
And can I just say that they're not to replace the child's AAI.
No.
They are there in addition. So it shouldn't be that because school holds those spare AAIs that the children don't need to bring them in. they're there as an addition if something doesn't work, or they've expired, etc., etc. So it's really important, I think, for parents and carers to understand that as well.
Yeah, thank you, Julie. That's really important. And I think something we've observed is kids taking increasing responsibility for when, actually I almost feel much more confident now. She carries her EpiPens all the time, rather than when she was at primary school. There was quite a lot of conversation about how close it needed to be, and my experience was like never close enough was what I wanted to say. But of course, at home she doesn't carry it from room to room, so you have to be reasonable. But I think when she sat at GCSEs, I was saying it needs to be on her desk. She needs to be there. Oh no, it can be close. And I was like, absolutely no, she needs to be able to see it. And I think that there's nothing that replaces having it on you all the time. And that was interesting, Taj, what you were saying about your daughter and her journey towards self and independence. And you shared some really positive experiences that she'd had, and it sounds like she's doing fantastically. Has she kind of come across any challenges or any difficulties that she's had to kind of overcome with that?
Yeah, I think she's probably going to embark on it. So, when they're young, you can almost control their environment to an extent. I can go into school, I can give her packed lunch, I can go to these parties, etc., and say, well, here's her food, her friendly food. As a 13-year-old, she doesn't want me to do that anymore. So I'm really trying to empower, and the conversations we have, which aren't the conversations I want to have, but they are, you will be in a position where you cannot eat anything and you do not feel safe, and you will not eat anything, and that is fine. And that's awful. That's not what I want to say. But if I can't make the environment safe and you don't feel the environment safe, the only thing you control is not having it, right? So wherever you go, you need to have snacks with you. And she's at that age where I can say to her, she went to a friend's party recently, and I had the conversation with the parent, and it's like, well, you're going by yourself, and you've got to risk assess this yourself. And if you do not feel comfortable, you just do not eat. And when you come back, I take you to McDonald's. That's not going to last as she gets older, absolutely. And I appreciate McDonald's isn't right for everybody, but I think she will face more of these as she gets older. And don't get me wrong, when we go on holiday, and we went to Paris in April, and that's the first time I didn't take any food with me for her, apart from her snacks and cereal in the morning. And it was tough. And I think there's the point that maybe someone made, which is when you're sitting in that restaurant as a family, everyone else might be enjoying it, but as a parent and the person who's got the allergy, you're just looking at each other and like, is today going to be okay? It's like, have a little bit and wait 5 minutes, have it a little bit more. So these are things that if you're going through, you only understand. I think for her, she'll have to start doing more of these by herself as mum hanging around with her isn't cool anymore. So yeah, it'd be interesting. All I can hope I've done, and everybody around her, is equipped her with enough confidence and knowledge to make the right decisions and feel that it's okay if she doesn't partake, because food is essential for a lot of the social aspects we have, but also fun, laughter, sharing jokes. That's also the other social element that we have. So just over-indexing on that. So yeah, fingers crossed.
Thanks, Taj. That's so relatable when you're looking at each other in a restaurant and you're thinking, when does this actually start to feel enjoyable? Yeah, but yeah, everybody, I think the more you do it, the easier it becomes. But yeah, it's not always a pleasant experience that it is for everybody else. Yeah.
And either when that meal finishes, it's when then I can down my glass of wine and think, we survived it.
I know. Well done us. Yes, that's how it feels, doesn't it? We've chalked one up. Yeah. I'm sorry, something's happened tech-wise that I can't see the chat. So if there's any key questions in the chat that anyone thinks we've missed or are really important to raise, then do shout. Otherwise, I'm going to hand back to Simon to wrap up. And thank you so much to Julie, Tracy, and Taj. They were all fantastic, and I learned so much, and I've been doing this for so many years with my daughter, but I've learned so much today. So big thanks to everybody, but especially the last speakers. I'll hand over to Simon.
Thanks, Louise. Before Tracy goes, there is one question around the cost of the adrenaline pens. Now, it's out of our control. There's nothing we can do about it as a charity. But they are expenses, as you say, and not that I'm aware of any other mechanism that a school can raise funds or find the funds, get the money to buy them. So they're not subsidized. It's a private prescription. It's not through the NHS. What tips do you give to a school to find that money?
Okay, so some schools ask their parent-teacher association if they will fund them, because out of the amount of money that is raised, typically it's a drop in the ocean from those events. I'd also recommend, actually, if you're going into a pharmacy, asking them if they will sell them to you at the NHS discounted price, because some will do that. And I know that some schools have had lots of success with that. I have also had success with talking to pharmacists and saying, look, this is life-saving medication for a school. What's your best price that you can give it to me? The online pharmacies are selling it for this, so giving them a bit of a haggle. Seeing if there is somebody that is willing to sponsor them. So we do have a business sponsor school program where, whilst that mainly pays for training, I found that businesses are happy to give the extra money for the adrenaline auto injectors. I've managed to get some support school to get some money out of, say, like the Lions or the Rotary Club. They're quite happy to look at funding things like this. So it's about tapping into your local networks and seeing if they can support the school, and we're happy to see what we can do to help as well.
Great, thank you very much. Let me just have a quick scan on those questions if there are any more. I think we've covered them all off. Thanks, Julie. Thanks, Tracy. Thanks, Louise, in particular, for chairing that session. Taj, brilliant. I mean, what a day, what an afternoon. It's been really, really informative. From knowing about the advancements in technology and in medicine, to how to talk to your GP, to a greater awareness around the impact of mental health and anxiety, and lots of the stuff that we're doing at Anaphylaxis UK, as well as, hearing from those lived experiences that would have resonated absolutely with everybody. And then the final session around schools. And I think what it's taught me is that we need to do more of this. Yes, and I think I've mentioned it more than once, is around our series of podcasts. But, we've got an afternoon's worth of expert speakers here that we could have given probably a full afternoon to and interviewed and heard them talking a lot more in greater detail. So I want to finally just thank the Royal Society of Medicine for inviting us to partner on this programme. And it's the first session, I hope, again, not the last, that's been held on allergies and anaphylaxis. There's a whole series going back many years around other health conditions that are fascinating and really valuable to listen into. And similarly with this afternoon session, I think it's been enormously valuable. Now, I understand it's recorded. Once RSM have done their editing and so on, it should be available in the Medicines and Me section of the website. But sign up to our newsletter if you are not already. Similarly with the social media, and clearly we'll let people know when that recording is available, together with all of the slides. So thank you very much for listening. Thank you very much for watching and staying with us from the afternoon. Some have dipped in, some have dipped out. But especially another thanks to all of our speakers, and ideally see you another time.